Good morning, San Francisco. Welcome to Prescription for Progress, our annual event. It's amazing to see so many new faces. Welcome to Prescription for Progress. As you saw in that video, a year ago, we were gathered together in San Francisco, technologists and innovators, global health leaders and practitioners, and not a mask in sight. How things have changed. And this event, the importance of it, I think is just highlighted by how things have changed, because this is the gathering every year where the global health community comes together with the technology community. And we think about partnerships, we think about innovation, we talk about how we can deliver healthcare for half the world that doesn't have access to essential medicine today. The coronavirus has only underscored how important these issues are as we see the race to develop diagnostics and therapeutics and vaccines, as we see the power of technology, the power of innovation, the power of partnerships. It just shows us how much more is actually needed. So thank you for being here today. Thank you for being a part of it. You'll notice we have a chat function throughout the day. This event is known for people getting together and finding partnerships. Use the chat function to do that. Tell us what you're working on, call out for partners, look out for opportunities to engage. We also want to hear from you. Share your comments, share your questions through the chat. If you're joining us on social media, you can use the hashtag Prescription for Progress. My Twitter handle is Raj_Devex. You'll see our journalists or reporters throughout the day. Follow them as well. I want to particularly call out our global partner today, which is Pfizer. An event like this does not happen without partners, and Pfizer's a long-standing partner with Devex on many of the global health issues that we cover around the world. We really appreciate their participation today, and look out for their session later on today on digital health technologies. It's going to be an interesting session with a community healthcare worker from Uganda directly calling in. You're going to want to hear about that. Let me tell you more about what's in store today. We've got a session on the WHO and how they're engaging with Silicon Valley partners. We've got a session on the latest private sector investments in global health. You're going to hear about how equity and global health is now a critical theme, and you'll hear directly from an African foundation, from another foundation head, and from a member of President Biden's COVID-19 task force on that important topic. You'll also hear from Peter Piot and Heidi Larson in my interview with that incredible virus hunting and fighting couple. We've got many announcements from the stage today at Prescription for Progress, including a really special one from Devex ourselves. And we close with Dr. Eric Goosby, who's always provocative. He's, of course, the former head of the former U.S. Global AIDS Ambassador. He's been a leader in global health on many fronts. Can't wait to hear what he has to say. We finished the public session with him and go into a private one with our pro subscribers where you can directly engage with Eric and ask him questions yourself. It's a good chance for me to thank our pro subscribers. We couldn't do the journalism we do here every day at Devex on global health without your support, and you get access to insider insights that come from our global health reporting. So we really appreciate that support you provide. If you're interested in being a pro subscriber, you're not, you can just email us at pro@devex.com. We can tell you more and hook you up with a free trial if you're interested. I want to also extend my thanks to other partners that you're going to be hearing about throughout the day and who help make this event possible. Our innovation partners, GSK, Medtronic Labs, and Novartis Foundation. Our ecosystem event partners, MSD for Mothers, or Merck for Mothers, as they're known in the United States, and the Bay Area Global Health Alliance. We're doing events with them around Prescription for Progress. Check out the Bay Area Global Health Alliance if you haven't yet, and if you're in the Bay Area, you might be interested to join. We end now and move to our next session. It's a good chance for me to say a special shout out and thank you to Catherine Cheney, my colleague at Devex, our West Coast correspondent. You know her well from her byline, the many events she helps host. This event, this whole conference really is her brainchild. She's made it happen, and I really appreciate the fantastic work she does to bring what's happening in Silicon Valley and the West Coast to our global audience every single day. So stay tuned for her right now, talking about technology and its role in the COVID-19 response. Catherine.
Thank you, Raj. It really is surreal thinking back to this event a year ago and talking on stage in San Francisco about the important role partnerships with the tech community would play in COVID-19 response. I don't think any of us could have anticipated that a year later we would have to gather virtually, but there are certainly many lessons to share in terms of the role tech has played over the past year and the role it can play moving forward. And that's what we're about to tackle in this first session to kick off our day. Joining us to speak about that topic, I'd like to introduce our panelists. Siobhan Byamukama is Managing Director of Babel Rwanda. Babel Rwanda is a subsidiary of Babylon Health, which is a global digital healthcare provider offering telehealth services. Jennifer Gardy is Deputy Director for Surveillance, Data, and Epidemiology on the malaria team at the Bill and Melinda Gates Foundation, though as you can imagine, over the past year, she's been very focused on COVID-19 response. Inder Singh is the founder and CEO of Kinsa, a company that uses its network of smart thermometers to curb the spread of infectious diseases. And Abu Campo is Director of Health at UNICEF, which many of you know is a United Nations agency responsible for providing humanitarian and developmental aid to children worldwide. So let's dive right in. Jen, my first question is for you. When you joined the Gates Foundation 2 years ago on the malaria team, of course, couldn't have anticipated what you'd be doing right now on COVID-19 response. You wrote that leveraging the potential of sequencing and data to advance global health, quote, will require thoughtful rollout if it's to be sustainably transformative, add value to local health programs, and be community driven. So that was your idea going in. And I'm just curious, how has that played out in your work on COVID-19 over the past year?
Oh my goodness, I think we could organize an entire conference around this theme. But for me, I think it boils down to when you've got an organization that holds those values that you just articulated dear, when everyone there has an internal compass that's really calibrated to equitable access to technology, even when you're in pandemic emergency response mode, your actions are going to be in line with that overarching ethos. And that's what we've seen with a lot of our work at the Gates Foundation over the last year. It is very much driven by those concepts of working with communities, adding value to the system, and doing so in a really sustainable way. And I think a great example comes from the work that our partners are doing, using genomics as a tool to track the spread of SARS-CoV-2 and these new variants of concern. You know, yes, we've got grantees in Seattle doing this. Yes, we have partners in the UK doing this, but we're also supporting this work to happen around the world, from Bangladesh to Zambia. And we're able to do this because we've taken that equity-informed view of deploying a transformative technology. So you can't just place a technology into a public health lab or a health system and expect results. You have to be cultivating relationships with scientists, with stakeholders on the ground. You need to understand the issues that are facing their problems. You have to be very honest with yourself as a funder that technology itself is very often the last piece of the puzzle, and it's really all about that upfront investment and ecosystem building and investing the time as well as the money.
Mm-hmm. Well, you mentioned cultivating relationships, and that leads me to Siobhan, because I know, Siobhan, that while you signed a 10-year partnership with the Rwandan government in March 2020, so this is giving every person over the age of 12 access to digital health consultations. Of course, that's going to be very critical. It has been critical over the past year. It will be critical moving forward. But laying the groundwork of those partnerships happened pre-COVID, happened pre-times of social distancing. So can you tell us, how has implementation gone for this partnership? What lessons have you learned? And what advice do you have, particularly for people who might be inspired by this conversation, but perhaps haven't laid that groundwork that it takes to make these partnerships work?
So our journey began in 2016 when we introduced telemedicine in Rwanda. But globally, we work in an environment where everybody uses their smartphone, but now we're coming into a place where only 10% of the population have smartphone, and the majority of the population use feature phones. And so we had to change, first of all, the way we do our service. So we have a call center in the city and employ over 100 doctors and 100 nurses to provide the telemedicine. And over the period of time, we've had to have partnerships with the government of Rwanda. We've had to be everywhere in the country where we put our platform in there. So we do the consultations, and we've done about 1.7 consultations since we started in 2017. We've registered over 2.4 million people, users. We do about 3,500 consultations every single day. So we really are everywhere in the country. And come COVID, we were all, you could say we were COVID ready, because part of the work that we were doing is to decongest health centers. And then later we were playing, actually in November, we started playing a more direct role because we're all dealing with all their symptomatic and symptomatic patients in Kigali. The highest number that we have received at any one given time was 6,000, and we're dealing with about 2,500, partnering with some companies in Rwanda who are funding part of this work initially. But in terms of lessons, I think it's very important to realize the importance of partnerships, because while you're dealing with digital healthcare over the mobile phone, which is doing the consultations, you need partnerships when somebody's going to do the laboratory works, when you're going to do prescriptions. People are all over the country. How do you partner to make sure that you give them the care that they need? The other thing that I found really, really critical is the importance of universal healthcare, especially in the developing world, or even, the importance of universal healthcare or insurance of people, because people don't have enough money. And so even when you tackle the problem of affordability and accessibility, because you're using mobile phones people already have, it's still expensive when you're going to do your tests, when you're going to get your prescription. So there's a really importance of that. And maybe finally, the other thing that I've learned is the importance of adaptability. So you're coming into Rwanda, you want to deal with everybody, because our mission is to provide healthcare to everyone on earth. and majority of the people don't have smartphones. So how do you treat people and provide the care using the feature phones that they have? So you'll be able to adapt. And also, as I said, we started in 2016, meaning that there were so many things that needed to be done. The regulatory environment, the legislation is not there. So you start working through these things, and you don't have to wait for perfect to get started.
Great call to action, and love the emphasis on partnerships. Of course, that is what today is all about. Inder, I want to go to you. And I actually heard you speak a little bit earlier this year at another virtual event and knew we had to have you here at Prescription for Progress. So thanks for joining us. You know, Kinsa is so much more than a smart thermometer company. You have a larger mission to build this early warning system for disease. So can you talk about how that played out in the lead up to COVID-19 and how connected devices can play into our strategy moving forward and preparing for future pandemics?
Catherine, thanks for having me. I'll start by posing the question that I posed 9 years ago when I started Kinsa. How do you stop the next outbreak before it becomes an epidemic, or God forbid, a pandemic, if you don't know where and when it's starting? And that was the question that launched Kinsa 9 years ago. Our mission since inception has been to create an early warning for outbreaks and to be able to forecast and predict how those outbreaks are going to spread. And what we did was we reimagined the first point of contact in the home with illness, the thermometer. And we piggybacked off of that behavior. Don't think of it as a thermometer that we've created. It's really kind of a medical guidance system that starts with a thermometer. But the key that unlocks the value is that consistent ability to talk to people when they're mildly symptomatic, well before they go to the healthcare system. And we get 3 unique data sets. We get where and when. You know, most of our users opt in for GPS location. So where and when are symptoms starting? How fast are they spreading? We literally can see in real time the attack rate or a proxy for the attack rate in the household. How fast is it spreading in a household? How fast is it spreading in a school? And how severe is it? How long lasting is it? And what are the severe symptoms? Now, none of this is rocket science. If you want to know where and when outbreaks are starting, you got to know where and when symptoms are starting, how fast they're spreading, and how bad they're getting. And so we fast forward to March. In March, what we saw was an unusual rise in transmission and fever incidents across the country, and throughout New York, in Florida and Texas. And this was when there were first cases in King County and Santa Clara. There were no cases anywhere else. And we saw these hot spots developing. So, you know, we felt it was a moral imperative to get the information out there. We launched healthweather.us, which is where we display a lot of our data. And we analyzed the data over time. And we and now more than 200 public health colleagues have analyzed the data. And we found that it was a 3-week leading indicator of COVID-19 spread. So today we can provide up to 3, even 4 weeks leading indicators of future case surges. And you know, part of the reason we've been able to do that is because of years of work on flu. What we're doing is taking the real-time data and subtracting out the fingerprint of what you'd normally expect from cold and flu, and what's left over is an unusual outbreak. And so that's how we're hotspotting today.
So interesting. And one of the things I hope to get to in our group conversation in just a moment is, you know, your background is in global health. You formerly worked with the Clinton Health Access Initiative. So to take the kind of work you're doing globally, including to low resource settings, what is the role of intermediaries? And I hope we can get into that in a moment. But first, I want to bring Abu into this discussion. And for those who aren't familiar, UNICEF is leveraging its experience as the largest vaccine buyer in the world to support countries to prepare their immunization programs for the COVID-19 vaccine rollout. So in that massive effort, I'd love for you to tell us, what are some of the ways you're partnering with the tech industry, whether it's smaller social enterprises we may not be as familiar with, or some of these larger tech companies whose names we know? Oh, and you're on mute.
Speaking thanks, Catherine, thanks, Catherine, for having me. Well, I mean, as you mentioned, I think UNICEF is the global procurement and logistic agency for the COVAX facility, who should be basically delivering, you know, the COVID-19 vaccines into 92 AMC countries. These are basically the low middle-income countries and the low-income countries. And in terms of technology, I think just looking in terms of having this vaccine management, stock management in delivering systems, I think technology is basically helping us of basically preparing the country. So we're utilizing open and source technologies in countries which are basically brought on by the governments, and to do their micro-plannings, prepare the countries, tracking the vaccines from their point of delivery from the manufacturers all the way to the country offices. So that's really one of the major involvement where with technology are, but also in the producing of those vaccines themselves. I mean, technology plays a very, very big role. I mean, we have new technologies when we're talking about the messenger RNA vaccines today, which is basically a new kind of vaccines which we haven't seen before. But I think if I have to single out one of the most important impact of technology right now, it's really in the fight of infodemic. I mean, false sources. I mean, social media has played a critical role of informing populations, but not always with the best information. So you have the good information and you have the bad information. I think, we had to work with those with technologies as well to basically bring closer to the population the right information and convince them. In terms of vaccine hesitance, it's another issue which we're basically tackling as well to really make sure that when those vaccines are reaching those countries, that the uptake of immunizations actually basically happening. And then the last point, and that's really for the future as well now, it's really with COVID-19 we have seen an exponential increase, in terms of waste, just because of the PPEs, because of the diagnostics, which are basically, multifold increased in every single countries. So new technology needs to be coming in, of really dealing with this entire medical waste in order not just to control the pandemic, but also making sure that we're contributing to the environment.
Thank you. And you mentioned the infodemic. That's certainly something we're going to get into today. In fact, following this session, we'll have another session looking at how the World Health Organization is partnering with big tech in COVID-19 response, and tackling misinformation has been a huge priority. I want to pose a question to all of you, and then maybe we'll bring in a question from our audience. But I mentioned earlier this point on intermediaries. So Inder, I know this is your background, if you want to come in first on this, and then would love to hear from others. When it comes to the potential of technology to play a really meaningful difference, both in tackling COVID-19 and ensuring continued access to other healthcare services, as Babel Rwanda is doing, what role can intermediaries play? And I assume many in our audience are in those kinds of organizations. So Inder, let's start with you.
Yeah, partnerships are essential to achieving the ends that we all care about. Partnerships between organizations and partnerships between the public and the private sectors. In my experience, those partnerships between the public and private sectors can be challenging because of conflicts of interest, both perceived and real. Whether they're real or not is there's always a question when someone from the public sector is talking to someone from the private sector about why are they speaking? And so the power of intermediaries is to gain trust on both sides. At CHAI, we would play that role. We would play the role of being the honest broker between the private companies, the pharmaceutical companies who cared about making sure that they weren't losing money, who cared about making sure that their business was sustainable. They cared about these things, but those were different incentives and different cares than the public sector had, right? And the public sector cared about ensuring supply, ensuring quality, ensuring low price. So in my experience, the intermediary is really essential to making the system work. I'll just provide a very simple example. And I learned the hard way when I was at CHAI. Just to provide a very simple example, I remember I gave my first talk at CHAI, and it was an audience that included both public sector colleagues, NGO colleagues, and private sector colleagues. And I used the word profit. Oh boy, 2/3 of the audience just turned off. They literally turned off. And I could see them just all of a sudden kind of, and that was an example of language matters. The way you speak to people, the way you talk about incentives matters. I learned very quickly that I needed to say reasonable return on investment, which is what I meant, but it wasn't what I said, right? And so language and understanding incentives of both parties to ensure that the collaboration is working is essential. And in my experience, the intermediary is critical in those public-private partnerships.
That's a really useful insight, just that one quick phrase and what a difference it makes in the room you're trying to reach. I see some nodding heads. What other panelists would like to jump in on the power of intermediaries? And then we'll go to a question from our audience. Go ahead, Abu.
Yes, I think, Inder has said it very, very rightly. I think for UNICEF, we are sometimes it depends on where we're standing on different ends. We can consider ourselves an intermediary, and sometimes we are at the other end. But just for the COVID-19 response, if you're looking at it, I think we are dealing with the farm industry who have basically developed, in record times the vaccines. Now we need to deliver it to the country so that it gets actually in the arm of people. So we are basically transporting those vaccines, to countries. We're utilizing, there's a huge partnerships which have been established in terms of transporters to help us basically in terms of transporting those vaccines in. They are received by UNICEF and handed over to the government. So there needs to be some kind of, trust relationship, to really make it happen. I think equity was a huge issue at the beginning, and we really had big worries that only the richer countries will be starting immunizing, and the low-income countries will not be basically accessing, those vaccines. COVAX was established. Yes, there has been some hiccups at the beginning, but our first planes landed yesterday, in Ghana, and it was from the COVAX facility, really making sure that the vaccine is distributed everywhere. So I think there needs to be this open discussions, and it might not be always easy, but there needs to be intermediary, because not one agency can do it all. There needs to be a partnership of basically undertaking these kind of actions. And I think the COVID-19 pandemic has demonstrated that we can work together, all together, to make an impact and really to overcome this pandemic.
Siobhan, let me go quickly to you, because I am trying to put myself in the shoes of our audience, and I imagine that some others might be in a position like yours, a tech-enabled health organization that seeks to partner with governments, which is so critical. And you've successfully partnered with a government in a very big way in the work you're doing in Rwanda. So what role has this intermediary role? How has the intermediary role factored into your work in Rwanda, or what other partnerships have been essential?
From the very start, we've had to really work towards partnering with the government of Rwanda, looking to make sure that everything is done according to plan. So we've had to work really hard to make sure that that this is done, according to how we're doing it.
Starting those conversations early. Yeah,
it's really, it was really complicated, having to have conversations with different layers of government, people, the Ministry of Health, RSSB, the insurance companies, and so many other people that are intermediaries to get the partnership going. So it has really been 4 years of hard work of having to speak to have conversations with different layers of people to get there.
Yeah, absolutely. To hear that partnership, again, the groundwork was laid, as you said, in 2016. So these things take time. I want to go to a question from our audience. And in preparing for today's Prescription for Progress event, I had conversations with a number of different leaders working in tech, working in global health. And one of the really interesting companies I got to know was Metabiota. So let's bring a question in from Metabiota, and then we'll see what our panelists have to say.
Hi, I'm Nita Madhav, epidemiologist, data scientist, and CEO of Metabiota, where our mission is to make the world more resilient to epidemics. At Metabiota, we use data and analytic tools along with on-the-ground work in disease hotspots around the world to help governments and businesses prepare for, manage, and mitigate against human and economic losses from epidemics and pandemics, including COVID-19. Technology is central to our work. During COVID-19, we've seen firsthand how data and analytics have provided situational awareness, informed operational decision-making, aided in business continuity planning, and fostered the development of insurance and financial protections. All of these can help governments and businesses weather COVID-19 and future crises. I'm excited to be a part of Prescription for Progress today and ask our panelists the following question. In your view, how can the technologies that have helped during the COVID-19 response make the world more resilient to future epidemics and pandemics?
It's a great question because it's forward-looking in our just 3 minutes left. So I'd actually love to hear from Jen on this to start. I know this is something you have a perspective on.
Yeah, for sure. I'll tackle this from the data angle. And I think when it comes to combating future pandemics, data really needs to be a lot of things to be truly useful, but two of those things are unbiased and accessible. And those are two areas that I think are really ripe for improvement in the public and global health space. I think we've seen over and over again that inequity is a huge issue in COVID-19, and there's some really important lessons to learn around how do we ensure that health data is being collected in a way that is capturing underlying disparities and is being used to plan interventions that address those disparities. You know, Inder gave us a fantastic example of the potential of connected diagnostics, which is something that we at the Gates Foundation are really, really excited about. But we need to make sure that those technologies are being distributed in an equitable way so that we really are capturing a true picture of what's going on out there. And then when it comes to accessibility, we've seen huge issues with access to data, the ability to quickly integrate multiple data sources into one single platform. And it's actually, I think, telling that many of the resources that people are going to for COVID tracking information are actually volunteer efforts. They're not coming from any official government agency. And I think it really does speak to kind of a failing of a lot of public health IT systems to make data accessible and to make it interoperable. And really, like, if you don't have data, you don't have a chance of getting ahead of whatever disease it is you're fighting.
Thanks, Jen. Inder, we'll go to you quickly, and we only have about a minute left.
Yeah, I mean, the key point here is how do you identify a potential outbreak that has epidemic potential in real time, right? Because by the time the healthcare system sees it, it's too late. Person one has spread it to person two. Maybe they were mildly symptomatic or asymptomatic, but then finally person three gets it. An incubation period occurs, and then they're sick enough to say, I'm going to go to the healthcare system. It's too late by that time. By that point, it's already spread in the community. And I think that's where we need to start going to people when they first have symptoms. Connected thermometers, wearables, they hold the promise of collecting real-time data. Now, the key missing ingredient here, and this is the one thing I want to hit, is this is a reflection of what Jennifer mentioned, is it has to be in those communities that are getting and spreading the disease. It has to be in underserved communities. Underserved communities don't have access to healthcare. They never enter the healthcare system in the first place. And we're very proud that 1 in 3 of our thermometers is given away for free to underserved communities, but we need that kind of global perspective. You have to have an underserved strategy in any epidemic. Newsflash, it's not new in COVID-19 that the underserved community is disproportionately affected. That is true in every single epidemic that has ever occurred. So the technology is an enabling factor, but we need those access programs at aggregation of data and the availability of data. I agree with Jennifer on all those points.
Well, thank you so much, everyone, for a great discussion. We had a question from the audience we didn't get to, which is around data security, but I encourage you all to use the chat, interact around that question of data security. I'll try to relay it to our panelists after this session and get back to that great question. But next up, we have a conversation on artificial intelligence and how AI can transform the way we think about healthcare delivery moving forward.
Well, welcome everyone back to Prescription for Progress. We're here to have a conversation about the future of health technologies and particularly where AI, artificial intelligence, fits into all this. I'm really delighted to be with all of you. I'm Raj Kumar. I'm the president and editor-in-chief of Devex. Many of us may have met in person when this event happened last year in San Francisco. Of course, we've moved it virtual, which is great because we get to reach so many more of you all over the world. And I really want to extend a warm welcome to you, and especially to my guests for this fireside chat, Ann Eretz, who is, of course, the head of the Novartis Foundation. And it's so nice to see you.
Nice to see you again as well, Raj.
And I'm excited to have this conversation with you. In fact, we have kind of an exciting announcement that you're going to hear during the course of this conversation. But let's just start on the substantive issue around AI and its role in health, especially in low and middle income countries, because this is an area of focus for you. I mean, you've had a long career at Novartis, and in the pharma industry before that, you've worked at the International Committee for the Red Cross. You have a lot of international experience, and you're arguing in some of what I've read and what you've said publicly that AI is a massive opportunity and it's something we can't miss. Why is that the case?
Yes, that's true that I say that indeed, because I feel AI is really the opportunity. The fact that we live in this era where that is existing is an opportunity for us to transform the way we think about delivering health and care around the world. And at the Novartis Foundation, we exactly have that mission, how we can advance data and digital-driven approaches towards improving population health. And the reason we do that, I think COVID has made it very clear for all of us. It's really a wake-up call that our health systems currently are not prepared enough, neither in high-income countries either. Also, everywhere in the world, we are not prepared to address all the burdens that are out there. So we have to transform our health systems and make them become from being that reactive health system, waiting for people to get sick before they do something, to become proactive, predictive, and eventually even preventative, so that the health system keeps the populations they serve healthy. And that's what we do at the foundation, in fact.
Yeah, I mean, during this pandemic, we've all become kind of armchair epidemiologists. We're constantly studying data and charts and looking at how things are done in different countries around supply chains. And I guess the question I have for you is, why AI and why for low and middle income countries? I mean, if someone's listening to this and think, well, AI maybe makes sense in the richest countries, why does it make particular sense in countries that are much less resourced?
Well, I think countries with less resources have most to gain from AI, but also most to lose if they lag behind. And that was, in fact, what we found out in a report that we came out last year with the working group on the Broadband Commission for Sustainable Development, where we specifically looked with together with our partners of Microsoft and many other experts in that group, we looked at how AI is already having an impact around the world. And what we saw in that landscape of over 300 examples where AI already does have a tremendous impact, it's not only in high-income countries at all. And it's also not only limited to clinical care. We know AI can help radiologists or pneumologists or pathologists make better, faster, more accurate diagnosis based on images. This we know in the clinical care, and it can help us standardize care and all these things. But what we saw is that it has a tremendous impact on population health. In fact, AI was the first discovering this unusual cluster of pneumonias in China, who discovered that COVID was a blue dot, an AI-driven motor, if you may. AI has tremendous impact on how fast and which way you can discover and develop new drugs, so new therapeutic options. During COVID as well, there was a screening of everything that already is on the market. Which one of these drugs could potentially have an effect on COVID? Everything was screened with AI, and benevolent AI came up with one drug that was on the market for rheumatoid arthritis that is now used in the treatment of COVID. Next to that, AI and patients use it a lot in the chatbots or other patient-facing solutions that are out there. There's this fantastic example from China, an insurance company, Ping An Good Doctor, they call it. And they want to provide every family in China with a doctor, with a health record, and with a health management plan. And they do that with delivering 24/7 hours in internet hospitals, internet health centers, and internet pharmacies. They deliver 1 billion consultations per day. Can you imagine what a response this is to a burgeoning healthcare need in Asia, for example, with the increasing aging population also?
Sure.
So there's massive examples of how AI already has an impact. And the last big use case we saw is on how it can optimize the workflow in health systems. You can automate your staff planning, you can automate your supply planning. So this was also instrumental in the beginning of the COVID pandemic for better planning of the protective equipment and the supplies, for example. So all of these elements already are out there. So we need to help countries in low income settings to tap into that potential and advance on their readiness to deploy it in their health system.
So how do we do that? What are the gaps? Is it that there's not enough data? You know, of course, connectivity is growing dramatically, even in low and middle income countries. You see them with cell phones everywhere. Is it that there's not enough data? Is it that government regulations aren't in place, so we can't protect the privacy of individual patients? Or what are we actually missing? Is it funding? What are the gaps you've identified?
Well, Raj, it's all of the above, if you may. So we found that there's 6 core areas that we distilled that from this landscape analysis on what is out there already. 6 core areas. So it's not only about data and infrastructure, contrarily to what people would think. You need good data and you need connection. Of course you need connection, and still half of the world is not connected. So that has to be fixed, absolutely, to not create more inequity. But data and infrastructure is only one of the core areas. The main or the first one is the people and the workforce. So digital and data science expertise is really lagging behind in the whole world. So we need to upskill the digital skills, but also the data science capabilities of all of our workforce, but also all of the students currently in formation. And we need to help them to get better in that area. Another area is, like you mentioned, that governments need to make sure that the data and the solutions can be used safely and keep people safe. So you need the governance and the regulatory systems, you need the funding, but you also need a design of your AI solutions that is really centered around an existing priority need. If you come with a well-intended solution that does not respond to a need on the ground, it will never get to scale. So it has to be needs driven and having the people at the center. And the last area was that you need very strong partnerships, public-private partnerships, obviously, but also between sectors. And the government has to have that coordination wall. Otherwise, you end up with a fragmented landscape again, like we saw in many low and middle income settings during the digital revolution. You saw that there's too many solutions out there and there's no real strategy behind it. So that is very essential, all of these.
I want to pick up on that last point about partnerships to talk about what I mentioned at the very beginning, which is kind of an exciting announcement that we're here to make on this stage, this virtual stage of Prescription for Progress. You know, as people may be listening in and hearing you, Anne, talk about how it's a complex set of issues that we have to better understand and then coordinate and collaborate around. We at Devex have been, you know, our journalists have been covering these issues a lot, innovation and science and tech in the global health space. And so we're so proud and pleased to announce we're partnering with you at the Novartis Foundation to launch the Healthtech Dialogues Hub, which is really meant to be an open call to build a community of practice of people who can help solve some of the exact issues you're talking about. And our journalists will be covering it and bringing, you know, their analysis to the table to say what's working, what's not working, what the challenges and hurdles are, what the solutions are. So I'd love you to just say a word more about this. We're so excited to be doing it with you.
Yeah, we are equally excited, Raj, about this new Healthtech Dialogue Hub we launched together with Devex. We've seen that the AI solutions during COVID, but also before, they have been booming. And with that became a booming or a blooming interest from many different stakeholders, being the innovators themselves, but also the policymakers or the researchers or funders. All are interested to explore further how we can best build these solutions. So there's a keen appetite from this different group of community, if you may. There's a very big appetite to learn how can we best translate a complex problem into a great idea and then translate that into an impactful solution. And that's what a dialogue hub like this can do, because we saw that there's innovators out there who are working on their own. They have no idea that there is others working on similar problems, or that there's data available they could tap into, or researchers are trying to get access to the right questions or even to the right data. And if you combine that all in a dialogue hub, you get so many more opportunities for collaboration. So that is going to make a tremendous difference in the world if we can make that happen. And in fact, it builds on something we did last year. Last year, we started this off based on a foundation we built with the Harvard Global Health Institute, MIT, and us at the Novartis Foundation. We built the DASH webinars, and DASH stands for Data Science and AI in Health, where we brought together all these different people, the innovators, funders, researchers, and policymakers around the table in 15 webinars. And we explored how AI can really influence the response to COVID. And this was such a success. I cannot say how many thousands of people we had attending, but there came a real nice outcome out of that. So we want to now further build on that and make Devex, with Devex, we are gonna make this a world-class dialogue hub, I'm pretty sure. So I'm very
sure
excited.
We will. And really, this is a call to action to everyone who's watching this, that the whole point here is to make this an open hub. So we want to ask other partners to join us, people who are working in technology, global health leaders, policymakers, academics, people of all stripes who care about this issue of how we can use AI to make quality healthcare a reality for people even in the lowest resource settings. And to understand the pitfalls and the challenges and deal with them now. We want your expertise, we want your ideas, we want your partnership. So this is an open call to you. We'll be posting in the notes a link to the site for this. You'll be hearing more about this from Devex and our colleagues here. We're really excited to bring our skill set and our community to this in partnership with the Novartis Foundation. Just delighted to be working with you on such an important issue, Anne.
For us as well. And I think really if we can also use it as a kind of a exchange or a repository even of what worked well, you can apply many of the solutions that have been validated in one context into another one as well. So it's going to be really very rapidly impactful. And that's why I'm so excited about it.
Well, me too. Me too. Dr. Anne Ertz, the head of the Novartis Foundation. Thank you for your time. Thank you to everyone who's following along here. Prescription for Progress. It's great to be with you.
Thank you so much, Raj.
So you just heard about this problem where there are too many solutions out there and no real strategy to bring those solutions together. And I think that is a real challenge when it comes to partnering with the tech sector on global health. The partnership we're about to talk about, the work that the World Health Organization has done to engage with the tech sector, I think is a good model of how to tackle that problem. So I just want to set the context here. Just over a year ago, Andy Pattison from the World Health Organization, who you'll meet shortly, took a flight from Geneva to Seattle and San Francisco to meet with different tech companies and talk about the role they would need to play in tackling COVID-19. They met at Facebook's headquarters in Menlo Park, California, and they formed what they call a tech task force focused on responding to COVID-19. So you're hearing from some representatives of that tech task force right now, and thrilled to have all of you. Let me go ahead and jump into some quick introductions before we get into this conversation. I'm thrilled to be joined by Rakesh Barania, who's the Director of Humanitarian Impact Data at Salesforce.org. Rakesh focuses on the intersection of emerging technologies and international humanitarian crisis response. So it's no surprise his focus over the past year at Salesforce has been on COVID-19 response. Kylie Holmes is the manager for global crisis and disaster response programs at Facebook. She leads Facebook's COVID-19 response program, which you'll hear more about in a moment. Machi Jadema is strategy and business development lead at WhatsApp, where she leads COVID-19 vaccine response partnerships. This includes a partnership with the World Health Organization on WHO Health Alert, which again, you'll hear about. And Andy, who I mentioned earlier, Andy Pattison is the Digital Solutions Manager at the World Health Organization. And partnerships play a key role in his work to amplify public health messages to more people through more channels. So I'd love to start with a question for Andy. You and I have spoken before about how the WHO prioritizes which partners it's going to work with. And one of your guiding principles is to meet people where they are, rather than try to drag them into your channels. So I wonder if you can expand on that point and just share what other advice you have for global health organizations seeking to partner with tech companies.
Yes, thank you very much. Thanks for the invitation. Yeah, we could spend a lot of time and effort pulling people into our channels, and indeed we do. But what I've done is I've flipped this strategy completely on its head. And to sort of explain how we do that, I want everyone to think back to when they used to travel to work. I know a lot of people are working from home, and how they would get to work. They would take the same car or the same bus or the same public transport along the same roads at the same time and park in the same car park and take the same elevator to the same office. These are habits and they're very hard to break, even if you want to break them. The same can be said for your digital journey. And so what we're trying to do is, rather than change people's habits, is meet them where they are. So your average mobile phone, your average smartphone will have 30 apps, but on a daily basis, people will use only 4 of them. My job is to get to the 4 that are on your phone, whatever they are. And the way we do that is we talk to our partners and give them the problem definition. We don't look at the solution definition. We don't say, oh, we'd like our content to appear on this application or this product. We say, okay, what we want to do is reach people with this content, and we leave them understand the solution definition and define the solution definition. And usually where the 2 problems overlap is a sweet spot, and we work in that sweet spot. And I would just encourage people to ask. If you don't ask, you don't get, right? So I would say have the conversations with the tech companies.
Great point. And I think one of the challenges in this moment, and maybe we can get to this in the conversation, is that day where you gathered with some of the speakers we're about to hear from in Menlo Park was so critical in forming the relationships that have continued over the past year. And now that everything's virtual, I think it's sometimes harder to form those relationships if you don't already have them. So maybe we can get into how that can be done. But next, I'd like to bring in Machi. And Machi, my question for you relates to the trade-offs that tech companies have to make. I mean, you have your day-to-day priorities, but you also have your partnerships with the WHO and other global health organizations. And I know for WhatsApp, you have to consider the trade-offs between helping groups like WHO reach communities at scale, while also preserving the experience that makes the WhatsApp platform popular. So you've said WhatsApp is in learning mode right now, and I'd love for you to expand on what are some of your key learnings so far.
Absolutely. And I think you nailed it in terms of framing the kinds of key strategic questions that we need to balance as we do more and more in this space, especially during such a challenging time. So we've learned a lot. I believe, we kicked off the partnership with Andy and team about close to exactly a year ago, specifically at WhatsApp. And there's been lots of learnings. And there are 3 that really stand out to me. So 3 highlights. One is keep it simple, and I'll kind of go into more details on each one. 2 is constantly iterate and learn. So to the theme around the learning mode, I was also thinking about that from a digital solutioning perspective. And then the 3rd is localize. And I'm sure everyone can understand why that's important within a global context for a global response. So I'm keeping it simple. I just wanted to kind of go back to what Andy mentioned, where he said a key pillar of their strategy and the digital side is really partnering with some of these platforms that are already on people's phones so that you're not dragging them into a separate platform if they're already engaging on a daily basis on an app like WhatsApp. One of the things I think we've nailed and we did right with the WHO solution is just having something that's simple and delightful to use. So anyone who uses the solution would see that it's quite intuitive, and that's not by accident. We actually spend a lot of time with the WHO team as well as with channel partners that we work with to build a solution to kind of be thoughtful about the user experience, keep it delightful. Anything from being thoughtful about, for example, adding stickers, which is something that we added later on, to making sure that it has videos and rich media, and just kind of not complicating the experience. So it continues to be something that people can relate to and can share with their family and friends. As I mentioned, the second is around constantly iterating and learning. So a lot of times with this digital solutions, what we find is, people launch things, they're successful, and then that's it, it's successful, and then they move on. I think one of the things that we got right, and frankly, that we learned over time that we needed to continue to do was we just need to continue to iterate and improve on what we've built before. So with the pandemic, there have been several needs, right? Initially, it was just core information. Over time, we realized mental health was an issue. Over time, there are just kind of other issues that crop up. So making sure that you're delivering that impact. And then the last is really on localization, making sure that you're putting in the right languages, you're addressing like the right issues people are looking for, et cetera. So those are the 3 we've learned so far. And I'm looking forward to the learnings we get this year. But I just wanted to highlight those 3 as key pillars that we've been focusing on.
Thanks, Machi. And given the focus on partnerships all day today, I should mention that in a lot of these partnerships between the WHO and large tech companies, there are others involved as well. So for example, between WhatsApp and WHO, you have the Prekilt Foundation and prekilt.org playing a key role. So I would encourage our audience to listen closely as there may be opportunities for you in the context in which you work to actually play a role, even if you aren't one of these large tech companies whose names we all know. I want to go to Kylie now. And Kylie, you know, WhatsApp is of course owned by Facebook. It's one of the many ways that Facebook is partnering in COVID-19 response, but Facebook is doing a lot in COVID-19 response. And you specifically are leading Facebook's work to provide ad credits and marketing agency support to more than 130 ministries of health, as well as WHO, UNICEF, and other nonprofit partners globally. And I know that your background is in humanitarian response and that global health equity is very important to you as you prioritize which partnerships you pursue. So can you expand on that?
Definitely. And I think, and also just picking up on a point that you just made about the companies big and small, in the group that Andy is convening, it does now include over 20 companies, including some smaller tech companies. So it is true, there is opportunity for people to engage at all levels on all things. Yeah, so I think equity is has been at the core of our program from the start, and this has been something that's been really important to us, and also an area in which we had to apply a lot of creativity, because we were using, I guess what you could say is one of Facebook's kind of superpowers in a way, is that we're using our advertising platform to spread messages on public health, but also helping partners do that. The ad platform, in the way that it works, is an ad auction. So it works slightly differently in all places. The prices are different. And also partners, although there's equal access, partners may not have the technical expertise needed to run ads. And we did find that with a lot of the public sector partners, for example, in the very beginning of the crisis. You know, many of our partners, including actually WHO, had, you know, less experience on running ads, especially on social media. And so we had to find a way quickly to level the playing field. And the way to do that for us was essentially to look for external marketing agencies. We call them Facebook marketing partners, but they're basically you know, ad agencies that specialize in social media. And we brought some of them on board to provide kind of free support and hours to our partners in combination with free ads, which we were providing. And that we found was a great equalizer, right? So it didn't matter if you had experience running ads on the platform before, or if you had your own agency or a lot of budget. When we were able to pair the free ads with the technical support from this external agency, it allowed countries, for example, and ministries of health that may not even have a web page that is super updated, to run these really sophisticated ads on the platform and target specific messages in specific languages to very you know, targeted groups on the platform. And we found that that was a really good way to kind of level things globally and ensure that everyone had the ability to run the same type of campaigns with that core preventative health messaging. We're doing the same thing on vaccines now, obviously watching carefully the distribution of vaccines and helping partners act when it's right. But the same thing, we're providing these resources in the same way moving forward, because we did find that it allowed partners and countries big and small to do something that we felt like was very powerful.
I think you know, a big challenge that will come up throughout the day is the challenge of misinformation. And of course, misinformation is spreading online and on social media, but social media companies are also working to tackle that misinformation. So it's really helpful to get some insights on that. And I think we'll return to the issue of trust later in this conversation, and the role that tech companies can play in helping to tackle this problem of trust that has arisen as a real challenge over the past year. I want to go to Rakesh. So Rakesh, for those who are less familiar, Salesforce.org is working to enable the distribution of 2 billion vaccines via the COVID-19 Vaccines Global Access, or COVAX facility. And data is obviously central to this effort. So I'm curious, can you tell us a little bit more about how Salesforce.org is partnering with some of these large international health organizations, not just the WHO, but Gavi, CEPI, and other international health organizations on COVID-19 distribution? And I want to hear about the role of data, but also partnerships in the work that you're doing.
Yeah, so thanks very much. You know, I think like every other tech organization represented here, you know, we had to pivot and really start to really think and innovate around an emergent problem that wasn't on our radar a little more than a year ago. And I think initially our first thought was, how do we protect the frontline healthcare workers and such? And so we at Salesforce actually sourced 60 million units of PPE during the early days of the pandemic, when PPE was in short supply for healthcare systems and for nonprofits and for governments around the world. And then initially, you know, that was something that we did early on, almost improvised. It wasn't a core competency. We weren't in the PPE business, but we really did realize that we needed to innovate in an ethical and protective way. When you are talking about data collection for people in various contexts, we want to make sure that we're approaching it with a certain, we want to move fast but do no harm. And so, for example, we came out with contact tracing applications for state, local, national government level contact tracing efforts, as well as for private businesses who needed to do contact tracing within a factory or facility or what have you. And then we ultimately moved from some of the initial, what I would say, adaptation, right? Digital transformation and resources to help organizations adapt to this new reality. I think then our focus shifted to more of a mitigation strategy, which is how do we bring our technology and our capabilities to actually mitigate the human suffering caused by the pandemic and all the resultant disruptions to that. And so Vaccine Cloud is really our centerpiece for that. So Vaccine Cloud is a platform that allows organizations at every size, whether it's a small nonprofit all the way out to these large international coalitions like COVAX, to manage their vaccine distribution or vaccine campaign on the pandemic. And for us, we centered on 3 elements of impact. We call it the 3 E's of vaccine impact, which is efficient, effective, and equitable. Right, that's what the world basically demands from this next phase. And so, we were really pleased yesterday to hear that Ghana was the first country to get a COVAX distribution of 600,000 doses of, AstraZeneca, and we are really happy to support that. But going to the partnerships, these partnerships are going to be continuing to roll out as we move through here. And so, like one that we're looking at right now is with the Net Hope Coalition, which is an emerging convening to get vaccines, and how do we use technology to enable the vaccination of the 235 million people who will need humanitarian assistance this year because of either conflict or disaster, right? The most vulnerable of the most vulnerable. How do we reach them and use technology to actually get vaccines to them? So this problem will continue to be with us for a while, but I think that these kind of partnerships and just engaging in the conversations is going to be so important for all of us, because none of us have the ability to solve it on our own.
Couldn't agree more. And it's why I'm so thrilled we're having this conversation. And earlier there was a question in the chat, which I encourage attendees to use, around data security. So Rakesh, in some ways you addressed that question directly when you talked about the way Salesforce is looking at this. Often you hear that move fast mentality among Silicon Valley tech companies, but move fast and do no harm. I think is really important framing. I want to bring in a question from a member of our audience and go ahead and encourage everyone on the chat to please post your questions. Earlier you heard from Raj Kumar about the Bay Area Global Health Alliance, and I believe we have a question from their executive director on this important question of trust.
Thank you, Catherine. The Bay Area Global Health Alliance was launched here at Prescription for Progress, and it's really good to be back. We are now a vibrant Bay Area global health community of 50 members from all different sectors: academic institutions, NGOs, tech, biotech, and other private sector companies. We've also been really fortunate to be able to have the opportunity to work with Andy and the WHO Tech Task Force. I have a comment and then a question. Tackling misinformation and disinformation is really tough, and I applaud the amazing progress that you all have made. But we're living in a time that some people call the post-truth era. Trust in government, in institutions, in science and media is at an all-time low. And that really complicates how we address threats, whether it be for nuclear threats or climate change or vaccine hesitancy. So my question is this: how are you dealing with this global crisis of trust? What partnerships are needed to help renew trust? And lastly, how can the Bay Area Global Health Alliance help? Thank you. I really appreciate this opportunity.
Thanks, Sarah. All right, who wants to take on this big question around trust? Rakesh, this is the signal for me as a moderator these days. You unmute, it's your time to go. Go for it.
Yeah, so I think it's a very, very interesting and very broad question. I think that we all have to recognize, and I agree with the premise of the question, which is that we are operating in a global crisis of trust. And trust is a function of execution over time. And so we have to show up consistently, we have to show up well, and we have to show up in fundamentally a transparent and accountable manner. Now, from our perspective at Salesforce, we realized that some of the data that we're talking about here may be considered extremely sensitive. When we talk about contact tracing and other things that directly relate to behaviors of individual human beings, that's very sensitive data. And so we wanted to make sure that we had we had a principled approach to how we engaged in developing these applications and how we're executing against them. And so we actually published our privacy guidelines for COVID-19. We wrote articles on how to rapidly innovate, but also do risk mitigation so that you actually had the speed of action, but also weren't accidentally creating a big brother type scenario. And we scrutinize all of our actions against a protective lens. The challenge is that in a crisis, right when you need to be most concerned about security and privacy, the crisis itself has a forcing mechanism that, unless you're really thinking it through, may cause you to ignore things just when they're needed the most, right? So just because we have to move fast doesn't mean we need to ignore security or ignore privacy or ignore civil liberties.
So well put. Thank you. Kylie, I know Facebook has done a lot of work on this issue of trust, and later today we'll be hearing from Heidi Larson, who leads the Vaccine Confidence Project. That's just one example of a partnership that Facebook has worked on as it works on this trust issue. But can you share, in response to Sarah's question, how you're thinking about this trust issue and how groups like perhaps the Bay Area Global Health Alliance might help?
Yes, definitely. I think that, this issue is obviously core to all of our work, and I think you can't build confidence in something if there's a lot of mistrust and misinformation circulating. And we certainly understand that as a company, and we're taking really strong actions on misinformation on the platform, using actually some tools that were already in our toolkit and generally used in cases where there's misinformation that caused physical violence in the offline world. A lot of those same policies actually apply to health information now, which is great. But as everyone here knows, a lot of the bad actors are quite prolific, and misinformation thrives in the absence of accurate information. And so this is why a huge part of our strategy has been on the work that I described earlier in pushing out that authoritative content from the sources that people know and trust the most. So not pushing it out in Facebook voice, although we've done that, also. We're really looking at amplifying those voices that are most trusted by the communities. And that means that we need different voices, and we need voices that look like the communities themselves. So in fact, Andy convened a group of us yesterday to discuss this very topic, just around how do we reach communities that might have higher levels of distrust. And I think that the themes that are emerging is that we have to diversify our strategy here and build trust by using organizations and individuals that are already trusted by some of the communities that may have very legitimate concerns or confusion around something like the vaccine. And so our focus this year is definitely diversifying. We're going to continue to partner with the ministries of health globally, with WHO, UNICEF, and some of the globally recognized public health organizations and institutions. But we're also working with people who are like group admins on Facebook, for example. Like, they already manage large communities of people. There's a lot of discussion. The moderators of those groups are generally trusted and known by the community. So we're working with those types of folks, or people who are just active in like a hyper local level and helping them put out content or amplifying their content on the platform. So we're trying to do both now, but really we want to ensure that there's a balance of the authoritative content while we're removing or downranking the bad content. So, and this is how the Bay Area Global Health Alliance is serving as a partner, as well as others, in that we're constantly reaching out to experts to help inform these strategies and take part in the response.
Thanks, Kylie. I think this important combination of not just technology, but tech and trust will likely be a theme throughout the day. I want to close in our last couple minutes here with a question. I'll start with Andy, and then if we have time, we'd love for others to jump in. Andy, I know that you hope this moment will be a turning point in terms of the way the global health community and the tech community partner. So can you describe, how do you see this as a turning point, and what should we be aiming for moving forward? I know you're working on the unmute, or my colleagues need to unmute.
Hi, I've lost sound, but maybe you can hear me. I caught most of that question. I think from my point of view, I think we really need to look forward as to, you know, what COVID has been a catalyst for change, and we've achieved a huge amount in the last 12 months together. What I would like to see is that we focus now on moving this, you know, once we finish this pandemic and we've all gone back to sort of normal lives, let's not lose everything we've done here. Let's use it as a springboard for future, for building, for growth, and use this to now to tackle other health issues, or, you know, other issues which is of concern to everybody. Imagine if we could deal with, for example, climate change in the same way as we're dealing with COVID, the whole world coming together, finding solutions, making it up as we go along for the good of everybody. On a personal level, looking forward, I just hope we have more respect for doctors and nurses, and in the future, and slightly less maybe for actors and football players. But that would be my personal wish.
Thanks, Andy. We're running low on time here. Machi, did you want to jump in really quickly?
Yes, for sure. And I'll keep it succinct. Just to echo Andy, I think, you know, that's how we feel too on the WhatsApp side. The future we've been dreaming about, COVID helped kind of accelerate that. And so how can we use this as a point in time to drive transformational impact, not just in a COVID environment, but post-COVID? I think that's incredibly inspiring, and also take the learnings from that to really tackle some of the biggest problems facing the world, whether it's climate change, global poverty, figuring out how we can really leverage digital to accelerate change and drive human progress.
Thank you so much. Really appreciate all of your time. And I want to just end by, Rakesh mentioned efficient, effective, and equitable. And I think we've gotten some insights on how tech can play a role in each of those areas. So thank you. Now I'll hand it over to Rajesh Gupta of Vero Biotechnology, which, you know, he'll be talking about this as a critical moment to advance new tools for infectious diseases. Following that, you'll hear from the U.S. Development Finance Corporation on ways to mobilize private sector investments in global health. Thank you all.
Hello, I'm Raj Gupta, and I help lead the global health efforts at Vero Biotechnology, an immunology company focused on the fight against infectious diseases. COVID-19 resulted in a fundamental shift in the development of therapeutics and vaccines. What was traditionally a decade-long process was compressed to less than 12 months. But two important questions remain. How do we translate this accelerated approach to other global infectious diseases? And how do we ensure those innovations quickly reach populations in need globally? To address the initial question, it helps to examine 5 key factors in the COVID-19 product development process. First, there existed a robust scientific base on coronaviruses and new platform technologies. So there was already a head start on the research portion of the research and development process. Second, platform clinical trials were created to effectively add or subtract product candidates. Instead of each developer needing to create its own infrastructure, developers could work with existing networks under standardized protocols. Third, activities that normally occur in a gated manner were actually conducted simultaneously. For example, we started clinical trials of candidates at the same time we embarked on large-scale manufacturing for those very candidates. Fourth, we had a high tolerance of failure. Multiple products were advanced at risk, knowing that many would fail. And fifth, financing was available for nearly every step of the process. This effectively mitigated the different range of risks for a given developer. Together, these 5 factors fostered an ecosystem of partnerships to form amongst academia, small biotechs, large companies, governments, and nonprofits. And replicating these 5 factors to create a similar partnership ecosystem for other global infectious diseases could get us equally to more products in a shorter amount of time. But we must also change our approach to getting those products to patients globally. The path from product to the patient in resource-limited settings could be built on 3 principles. The first principle is to financially empower low and middle income countries. We need a fully financed pandemic procurement fund in advance of the next epidemic so that poorer countries are not left behind in the initial supply allocation. The second principle is to develop critical operational solutions. These include harmonizing various regulatory requirements into a streamlined process, expanding the global biologics manufacturing capacity for both raw materials and finished product, and pilot testing of in-country distribution mechanisms to ensure effective execution during an actual crisis. The third principle is understanding we need to deliver multiple innovations over time rather than waiting for the ideal technology. We should be operating under the premise that the technologies evolve and become optimized over time to respond to potential considerations like pathogen evolution or patient-centeredness. Ultimately, when we have a technology that's ready to deploy in high-income countries, we should have the partnerships in place to be ready to deploy it in resource-limited settings. For decades, comparative statistics have highlighted health disparities between the rich and poor. COVID-19 only further exacerbated that divide. However, accepting this as status quo is no longer acceptable. As a just society that values human life equally, we must develop a more equitable response to global infectious diseases. In closing, I'd like to thank the Devex organizers for the opportunity to speak with you today. We will only achieve global health equity through partnerships, and I look forward to working with you on some of these efforts.
Thanks to Rajesh for those remarks. My name is Adva Saldinger, and I'm a senior reporter here at Devex. And I am glad that you could join us for this conversation about mobilizing private finance for global health. Part of the reason we're having this discussion today is that historically there hasn't been a lot of private investment in global health, particularly from DFIs and some traditional sort of development finance institutions. A lot of the funding has come in the form of grants and loans. And so we're going to dive in today to try to better understand sort of why that is and look at a few examples of where that is happening and what we can learn from them. So to start things off, I'd like to introduce Nafisa Jawani, who's the Managing Director of Health Initiatives at the U.S. International Development Finance Corporation, or the DFC, as many of us know it. Nafisa, welcome. Thank you so much for joining us today. I wanted to really kick this conversation off with a question to you about why haven't DFIs invested as much in the health space as they have in other sectors traditionally? What are some of the key barriers? What can be done to address those barriers? And for a little bit of, historical data to sort of start us off, OPIC, which was the DFC's predecessor, had only about 10% of its portfolio invested in health investments, right? So much smaller than other sectors where DFIs have traditionally been more active. So what can you tell us about why that is, about why things have been constrained in this space?
It's a great question. I get asked it very often, even within our own agency and with our leadership. And I would say, a couple things. One is, you brought up that most of the time when we think about global health, we think about aid and grant dollars. And that's how we've traditionally invested in global health. And here's an opportunity for us to think differently. And there just hasn't been as much private investment to create sustainable health solutions. Other than that, I think that there are real risks in doing global health projects for DFIs. And it's not surprising, but it's hard for us to ignore, especially when you look at risks around business models that may be incredibly innovative, but have insufficient focus on commercial viability. And we see that often in the global health space. Another area is that we often see companies who are transitioning from academia to the NGO space and coming to a DFI that just may not have had a good sort of transition of how to interact with the DFI. And so they're trying to get some technical assistance on how to do that, hiring a CFO, creating a business plan, understanding what an ROI would look like for a DFI. I would say another risk, and you probably know this well, Ada, given all the work that you're doing, is emerging markets have a greater risk around everything from diligence, executing, deal structure, which increases the overall transaction costs. And of course, there's a risk of failure relative to other opportunities. And that is something that I think DFIs are obviously worried about. And I would say the last sort of barrier that I might want to point out, especially as we're thinking about PPE or vaccine manufacturing is that there are legal and regulatory structures or lack thereof, which also make it really difficult for DFIs to push forward an investment in that space. All of that being said, at least for DFC, I will say that there has been a tremendous level of support from across the USG to support these innovative global health projects to really create sustainability around a lot of the work that we've done from an aid and grant dollar space.
So I wanted to follow up on that because the DFC last year in May announced the Health and Prosperity Initiative, which is a commitment to invest $2 billion in 3 years in global health. So give us a little bit of a progress report. How much has the DFC invested thus far? Where are you sort of focusing your efforts? How much of this is, sort of COVID specific versus, other diseases or health systems? And what have you learned thus far? How is it impacting the way DFC is doing business? Is it, really actually ramping things up so this is more of a investment line for the DFC?
So I'll start off with answering your last question. It is a priority for this administration. It's a priority for the last administration, continues to be a priority for this administration, and a strategic focus for the agency. I have learned a lot in the last few months, but I will say that we as an agency, we are ambitious. And I think over the last 9 months, seeing the way in which we have moved much more quickly on transactions, I think, than we ever have before by being much more creative about how we do due diligence or finding ways to be a little bit more streamlined in terms of our processes has helped us, I think, move through transactions a little bit quicker. So I will say that we are ambitious. The last few months have made me appreciate our agency even more today as we continue our strong and strategic focus around global health. And like you mentioned, it does not come without challenges. I want to say that, for us, what's been helpful is learning from DFC's, one of DFC's first initiatives that was focused on global health. So while we, announced the Health and Prosperity Initiative in May, the DFC had its first initiative, which was the Moms Initiative, and it's a partnership between the DFC, USAID, Merck for Mothers, and Credit Suisse to invest $50 million in companies focused on maternal health. And learning from, that partnership, I think, has been incredibly helpful and informative for how we were thinking about the Health and Prosperity Initiative. To date, the Moms Initiative has invested in 3 companies that are improving maternal health outcomes in sub-Saharan Africa, which is LifeBank, Johnny Clinics, and Penda Health. So I would say that, one, while there was a small portfolio focused on global health prior to us transitioning to the DFC, it was a focus then, and we're using those learnings to say, how do we improve how we do business now? Maybe a few other things to point out. When we were OPIC, we had a US nexus that was required, and that no longer is a requirement for us. And I think that's made a big difference, especially when you think about the global health space in terms of what we can do. We also have an equity tool that did not exist before. We have a technical assistance tool, which is, a soft loan. And again, I think those are some of the tools that we just didn't have as OPIC that really have helped us to accelerate some work in this space. DFC is committed to advancing new global health investments across the world. And we were really focusing our efforts on how to combat the pandemic, of course. And so everything from looking at opportunities around vaccine manufacturing, diagnostics, therapeutics, PPE, but also really how can we support the global health ecosystem long term? Okay, because today we're dealing with this pandemic and tomorrow it's going to be something else. So how do we think about supporting the global health ecosystem long term through healthcare delivery, digital health, supply chain and manufacturing for both communicable and non-communicable diseases? I say this often because I think sometimes we forget how important NCDs are as well. And we also continue to look for projects focused on expanded access to clean water, sanitation, nutrition. And again, we're looking at, projects that are viable that can stand on their own commercial merits. And if we continue to do that, our agency can help create a global health ecosystem that is self-sustaining. And again, for me, coming from a public health background, I really think about how do we outlast immediate crisis and prepare for the next.
Thanks, Nafisa. I want to now bring in a couple other people into our conversation. Ben Hubbard, the CEO and co-founder of Parcel, and Kennedy Okongo, the East Africa director of the Medical Credit Fund. And Ben and Kennedy both have experience structuring deals that bring in private capital and have worked with the DFC. And so I want to ask both of you to tell us a little bit about these interesting and innovative deals that you've been a part of, and why you turned to a DFI to help finance them, and sort of how you went about that, and how you think it's best to engage with a DFI like DFC or others. So Kennedy, let's start with you. Tell us a little bit about the Medical Credit Fund and the recent deal that was announced with MCF and the DFC.
Thank you, Adva. The Medical Credit Fund has been in existence for over the last 10 years, having its operations in sub-Saharan Africa in 5 African countries. Over time, we've been providing debt capital to primary healthcare providers, that is the health SMEs in the market, sourcing money from a few investors here and there, just putting it together, coupling that with the technical assistance. So over the period of 10 years, we've deployed close to $100 million US dollars in debt capital, done in over 5,000 loans to around 2,500 clinics, meaning a majority of them have been able to come into the cookie jar more than once, taking a facility, taking a repeat facility, and taking another facility. Again, now coming back into last year where COVID hit, we've been in this field for over 10 years, just trying to assure that we have clinics that are well prepared to take care of the normal ailments that we have, communicable diseases, non-communicable diseases. Then the pandemic hit, and all of a sudden, the discussion is all about PPEs, the discussion is all about coming up with vaccines and all that. All this time, we are forgetting that malaria has not taken a break. All this time, we are forgetting that tuberculosis has not taken a break. All these other diseases that we've been suffering from in Africa haven't taken a break, yet everybody else is focusing a lot on just eradicating the pandemic and finding solutions to the pandemic. So you found that now the playing field has been skewed. Everybody's talking about this, yet all these other things that exist and having a very high mortality rate in Africa are being forgotten. So at this juncture then, the Medical Credit Fund that really wanted to ensure that whatever clinics we've always brought up to speed are not left behind, we had to look for a partner who was able to not only come in and look into the future with us, and also not forget where we are coming from. So we got into this arrangement with the DFI. We got a facility of $30 million US dollars just to ensure that all these other existing diseases are not forgotten at any given time. Thank you, Adva.
And Ben, tell us a little bit about the deal that Parcel has done. And I know another partner there is Lloyd's, which is a really old insurance company that hasn't been involved in quite the type of thing that you guys have helped to put together.
Yeah, sure. Thanks for including us. I guess maybe a couple of pieces of context. Parcel as a company, we're a technology company. We make sensors and software, little sensors that ride with sensitive products like vaccines. So we understand what happens to them as they're being stored and shipped around the world. We're also an insurer, so we insure those products in the case something bad does happen. And I think the other interesting piece of this, I used to run something called the Development Credit Authority at USAID, which is now part of DFC, and had a little bit of experience on the DFI side of this, which in healthcare has always been a challenging space to lend into, to invest into. And one of the interesting learnings I've had since leaving government and starting Parcel is this kind of invisible, really important role of insurance in lower middle income countries, low income countries. And we have all these traditional DFI tools, credit enhancements, loans, now equity, that can be used, but haven't traditionally been used to support insurance. And as I looked deeper, you see the sort of market failure or market gaps around insurance. So if you're a small business, yes, you need a loan, but you also need to get insurance to bid on that government contract. You also need insurance as part of getting the loan. And you can kind of look across a number of different sectors, but in healthcare, as it turns out, if you're a country, you need insurance to get the vaccines from Gavi. You need insurance to get the AIDS and TB and malaria products from the Global Fund. And so it plays this very important invisible role. But the other part of what it does, in addition to just sort of protecting the products if something bad happens, it brings private capital into these sectors where they now have skin in the game, and they're very incented to want to help manage the risk of those. And so we looked at the vaccine supply chain prior to the pandemic. It was actually a year ago, Nafisa and I started to get really excited about this. How can we use DFC's tools to address this market failure and this huge, super important protection gap? And then with COVID-19, obviously that is just accentuated the need, where we have a lot of really important life-saving products that are unprotected in these markets. So it's a simple and a complex deal at the same time, but at the core, what we're doing is we're pairing risk-sharing tools that DFC has, and they're sharing risk with the insurance market, a dozen other insurers, and then we're using data and visibility as a technology company to be able to give insurers visibility into these risks, to be able to give the client, ministries of health, Gavi, risk management, to make improvements. And doing that, we've been able to unlock billions of dollars of insurance capacity to be able to insure COVID-19 distributions around the world. And so we're really excited. This just started January 1st. We started trading. We did it in lightning speed, at least for a development bank. It was very fast. Not as fast as maybe a venture capital investor, but certainly very fast. And we're really excited about it, and lots of good lessons, I think, for both Nafisa and I and our teams in doing this, because it really was a really first of its kind transaction. It all takes place at Lloyd's of London. This is the first time a government has ever invested in the Lloyd's insurance marketplace. So we're really thrilled to have broken some ground.
Thanks, Ben. Ben and Kennedy, I wanted to ask both of you, because you're working in this space, about sort of what you see as the greatest challenges of mobilizing private capital for these investments. You know, Kennedy, you were talking about how the Medical Credit Fund has been doing this for a long time, trying to raise money from investors, but I'm sure it hasn't always been sort of easy to get the scale of investment that you might want to meet the demand that's out there. And Ben, obviously, you know, drawing on your experience in government in the US, I think you have sort of a really interesting take on what the potential bridge also is between sort of that more grant capital or loan capital and sort of this private capital, and where we might see some gaps and how they could be addressed. So do either one of you want to jump in on that first?
Yes, Adva, thank you. Just to pick on what Ben had earlier said, that the health space is considered to be a very risky and volatile market that nobody really wants to look at. If you look at it currently globally, everybody wants to be at the Silicon Valley. But in the Silicon Valley, you will not find a health SME being discovered. Health is something that has been here since time immemorial. As long as somebody is born today, you're bound to visit a hospital in one way or another. Either you'll be born in a hospital. Unfortunately, if you are born somewhere in the rural villages in Africa, you may not be in a position to reach a hospital. But immediately after that, you may need to see a doctor or something. So we've been having this challenge of everybody having a perception that health SMEs are high risk, which has been demystified over the last 10 years that the Medical Credit Fund has been in operation. We've really proved to the world that health SMEs are actually bankable. If you look at our non-performing book in relation to the industry average, we are normally always way better, because at any other given time, the worst that we hit is a worst case scenario of 3% non-performing. But if you look at the industry average, comparing with the commercial banks, comparing with the non-financial institutions that are operating in other sectors, you find them struggling with around 15, 20% of a non-performing book at any other given time. So this perception of health SMEs is actually very risky. It's something that a majority of the people are looking at it and saying, no, this is a venture that we really don't want to look at. Secondly, we've not really had a good government support in terms of bringing private health SMEs. So a majority of the time we'll be left to worry about grants, and grants are quickly drying out the world over. We cannot really rely on grants on a very key thing, that is the well-being of the workforce of a nation. Because the moment a nation has unhealthy people, then it means that nation by itself will not actually survive. So the key thing is to ensure that, first of all, everybody is healthy, everybody is able to attend to their duties. So this notion that now we cannot really, we want to build in a lot of motor vehicles, but who are going to drive these vehicles? We want to put in a lot of machines to be able to do X, Y, Z. But if the people are not really healthy to run these machines, then it means the entire world is running in a different directions. So at the Medical Credit Fund, over 10-year period, we've proved to financial institutions that health SMEs are actually bankable. And we've given loans to as little as $100 to a health SME facility somewhere in Africa. And these loans have been repaid, and that's why we're having customers coming back and back and back to us. So yes, we've demystified this myth. Thank you.
I mean, quick comments on that. I think that, you know, it's very important, to Kennedy's point, that we're bringing and crowding in private capital and private sector innovation. And DFC, you know, has a risk appetite for doing tough things in tough places. And that's really important. We wouldn't have gotten this partnership done without that kind of appetite. They're also, in some ways, very risk averse and bring kind of a lender mindset. So I think one thing we need to do in the health sector is bring a little bit more of an equity mindset in terms of taking more risk, looking at kind of long-term value creation rather than necessarily cash flow based, because it just requires more patience. And I think those are tools at DFC that they're nascent now, but are developing, is my understanding. I think that the more DFIs are teaming up with the large spenders in this sector, so the Gavis, the global funds, the PEPFARs, USAID, it's really important that donors are not crowding out the private sector and private capital. And as much as people say they're not or don't want to, it happens. And I think the more that they're creating market incentives, the more we're getting private actors into these sectors, we're just going to have more of a sustainable financing structure. But it really does, all the money in this sector right now is from donors. And it does suppress private capital and private innovation. We experience that directly ourselves.
Yeah, well, speaking of the Global Fund, John Fairhurst, who's the head of private sector engagement at the Global Fund, has submitted a question for us. So I'm going to go to that video questions. Our producers are going to play that for us now.
Working in an organization that has 20 years experience of reducing the impact of disease in low and middle income countries, we've seen up close the direct and collateral damage diseases do to people's lives, their livelihoods and their country's economies. The last year has shown the world the depth and extent of the global economy's connection to global health and the effectiveness of health systems. And looking at the basic economic analysis of the damage versus the cost of prevention, it's clear health has been a blind spot for DFIs and the private sector. A survey of Fortune 500 companies in 2019 showed that only 9% have a global health strategy, and the majority of those are pharma or health companies. We're all desperate to go back to business as usual, but in the space of investment in global health, none of us, including those in the development space, should want to return to that kind of business as usual. If we are to collectively and radically change this underinvestment at real scale, it's about new attitudes and new types of instruments, new platforms. We at the Global Fund are working on some of that, but what does this look like to you?
So we've only got a couple minutes left here, but if I can go to each of you for just sort of a 1-minute response to his question, that would be great. Kennedy, do you want to kick us off?
Thank you, Adva. Just to answer John, I would say that the future looks really bright and even is getting more brighter. Looking at the arrangement we've had with DFC and getting $30 million on the table at Medical Credit Fund, we are able to look at this and come up with innovative ways to ensuring that money actually reaches up to the last. We've come up with innovations whereby currently we are dispatching a total of $4 million on a monthly basis through a mobile platform that does not involve a lot of analysis, a lot of people in the system, in the process, so that we are able to deploy this capital quickly and faster. And so with the help of DFC, with the help of this initiative that we are having, then we'll be able to actually move even quicker to ensure that all these primary healthcare providers, all these diseases that we are having in Africa are actually taken care of. Right now, if you walk into a clinic somewhere in sub-Saharan Africa with just malaria fever, everybody first thing is
Great.
Before.
We've got 1 minute left. So Ben and Nafisa, if you want to just quickly.
10 seconds for me. I think it's really a mindset around how do we use donor capital, if I'm answering the Global Fund question, not to go and do the job ourselves, but to de-risk getting the private sector to come in and do it with us or for us. And that's not suitable for everything, but it is a change of mindset. And if you can help create the incentives and take some of the initial risk out, you can actually prove a market and shift this to a much more sustainable model.
I will finish things off with, I feel like this is the time for global health to make its mark and to shift the way that we traditionally think about things. And I guess, my call to others is, to answer the question around how do we sustain this new way of thinking and how do we plan ahead?
Great. Well, thank you all so much for joining us and being here. Obviously, this can be the start of many more conversations because there's a lot of ground for us to cover here. And to everyone who's joining us, I want to say that next you're going to hear from Hala Audi, and then my colleague Amruta will moderate a session about global health equity. Thanks.
Thank you.
Thank you.
The Trinity Challenge is a coalition of members united to better protect the world against health emergencies using data-driven research and analytics. I don't need to convince this audience that we need to do better now against COVID, and we also need to be better prepared for next time. I think we would also all agree of the potential that data and digital tools bring to managing better health emergencies such as this one. And we've already seen a massive progress and innovative use of data sets during the COVID pandemic, whether it's using social media, chatter and surveys, or movement data to help surveillance of the disease and infection spread forecasting. We've already seen some of the benefits of using data differently or better. From my background working on antimicrobial resistance, I also know very much the importance of making the case for early intervention. It is simply cheaper and easier to act early. And this has, of course, panned out very much during this pandemic, but we know it will continue. And to make that case convincingly, we will need a focus on social science, behavioral science, and economic data to help inform the decisions made by governments and business leaders in terms of investing in prevention. There's finally some urgency to act now. One is because there's been an accelerated pace of progress during the pandemic, and there's something really urgent about learning the lessons of what has worked well this time and can be reproduced at scale and should be saved and become what we call global public goods that can be picked up and used by organizations who are delivering on public health objectives. So what are we doing in the Trinity Challenge? The main work that we do is to set up a global challenge to pool the best ideas from anyone, anywhere, that will help identify, respond to, and recover from outbreaks and epidemics. The challenge is already open. The window for application will close in mid-April, on the 15th of April, and we're working on an inaugural round of awards to distribute substantial prizes in June this year. So I hope a lot of you will have a look at more details on our website and consider applying. What our members do, in addition to setting up and designing the challenge that I just described, is work across our coalition on specific projects that are set up to address some of the toughest questions posed by this pandemic, questions that we know will continue to be relevant outside of health emergencies and during the next ones, which we know are around the corner. So the kind of topics we tackle go from working on data and digital platforms to increase vaccine confidence and reduce vaccine hesitancy. We are also working on learning the lessons from the best surveillance tool, as well as infection forecasting tools, so that we can package and make these tools and these innovations available to more of the decision makers in government and in public health in more countries in the world. So this kind of collaboration that happens across our membership is one of the most important part of the work that we do, because it cuts across sectors and it brings academic thinking, which is the bedrock of what we do in the Trinity Challenge, with the innovation and data that is often within private sector businesses, but that we need to bring to bear to inform the decisions that are made to manage this pandemic and the next ones, as well as public sector and not-for-profit actors who are at the delivery end of public health interventions. So by bringing these three sectors together, academia, the social sector, and leaders from business, we think we can make the most difference in practice. And I know this is very much what Prescription for Progress is all about. So it's a pleasure to be here today talking to you. And before I leave you, can I just encourage you once again to check out the detailed information about the challenge that is now open. Our website is thetrinitychallenge.org, and all the information is there. The window for applying into the challenge closes on the 15th of April. I hope many of you will check it out.
Hi everyone, I'm Amrita Batnal and I'm an associate editor here at Devex. I'm very happy to be here today to talk about this very crucial issue of global health equity. To discuss this today, we have with us three esteemed panelists who I will quickly introduce. We have Lois Pace, who is the Executive Director and President at the Global Health Council. We have Latanya Mepfret, who is the President and CEO of the Global Fund for Women. And we also have with us Dr. Kennedy Mubaiwa, the CEO of Higher Life Foundation. Welcome, everyone. We're very happy to have you here today.
Thank you.
And like I was saying before, this is a very crucial topic, something that we at Devex have been covering for a while now, and it's becoming even more urgent and important during this pandemic. So I'm really excited to dig in and look at some deeper perspectives here with all of you. Lois, if I could just get started with you for the bigger picture, over the last 1 year, we've had a lot of these conversations. Around the time of George Floyd's death, there was a lot of conversation about racism within the US, but also outside in the global development sector, and especially in global health, given that we're in the middle of a pandemic. So from that moment, do you think we've emerged into action, and what do you see sort of as the big opportunities of this moment?
Yeah, I think we have actually. I don't know if action is the right word, but I think people are certainly ready to act, right? What happened last year is not something some of us were surprised by, unfortunately. And as you mentioned, this was sort of not even a culmination, but a line in the sand when it came to calls for decolonization and for anti-racism, calls that people have been making in the years prior. But I think what was different about last year is that people had to sit down and pay attention to it. We're in the middle of a pandemic, and folks had no choice but to focus on the inequities brought about by COVID, but also just glaring across a number of other issues. But I want to step back and kind of make sure we're all talking about the same thing, because when I talk about decolonization, let's say, as a framework. I think you have different parts to that. And I can appreciate Dr. Madhupai, he talks about all of these different elements to it, whether you're talking about race or racism, whether you're talking about money and power, whether you're talking about privilege, broadly speaking. And so I think it's important that people start to understand and unpack what we mean when we talk about dismantling this architecture, and understand who's at risk if we don't do that, and also who benefits if we do.
Yeah, you brought up a really important point of privilege and power. So I want to come to you quickly, Latanya. How does that sort of impact women and girls? And, because women and girls around the world are already in a position of vulnerability, they're already being ignored. And then when you add this layer of colonization and racism, how does that, play out on the ground? And how do you as an organization handle that?
Yeah, thanks, Amrita. And I, absolutely agree with Lois. And this is, unfortunately didn't start with COVID, but COVID has highlighted some of our worst inequities. And just for women and girls, I want to, again, as Lois framed it, make sure we understand we didn't start with COVID. This is a part of the society and the world that we live in, right? These intersectional inequalities. But for girls, it starts with, the 140 missing women and girls, based on son preference or gender-based biased, sex selection. And it continues through the life cycle, right? So we've got approximately 300,000 women that die from preventable causes related to pregnancy and childbirth each year. And worldwide, 1 out of 5 women still have no access during childbirth to a skilled health professional. And these are preventable, they're easy to manage, but the complication is around these inequities that we live in. And who decides to do what? The power and privilege conversation that Lois was talking about. But now we have more sophisticated, disaggregated data, right? We can nuance our responses so we can target more marginalized populations. And so there's really no more excuses in the global health world as far as we feel like Global Fund for Women. The sector knows who needs the support and we know where to fund it. I think some of it comes down to centering women and girls around the solution to what we're trying to do. And the statistics show, that grassroots gender justice organizations really are moving the needle. They're the real innovators in their communities, in their states, in their countries, and in their regions. And they're closest to those that are affected by these inequities. And so we need to make sure that our partners around the world who are doing this amazing work, who are leading these incredible movements, have access to resources. I think it goes without saying, roughly 1% or less of funding, worldwide goes to gender equity and grassroots feminist organizations. And so if we want to decrease global health inequities, we're really going to have to get at this power and this privilege, and we're going to have to fuel the resources that these more marginalized communities need in order to create that change. Thanks.
Right, thank you so much for that. And you talked about who gets to do what. I feel like that really is the central question of the idea of decolonization and sort of bringing power back to the people who things are really affecting, who issues are really affecting, and sort of bringing decision-making to them. And that brings me to you, Dr. Kennedy. You are in Zimbabwe, you're sort of living this day in and day out. So can you speak to this issue of, how do you sort of decentralize power, and how do you make decisions in a way that, involve people on the ground?
Amrita, thank you very much for that question. So I'm with Hala Foundation, and we are Zimbabwean based. We've been running our foundation now for the last 25 years. And the issue around equity for us, if you look at our vision, I think what we have done is we've made equity the DNA of our vision. Our vision is that we look at providing a platform for people to fulfill their God-given purpose. So from that basis, our focus is to make sure that we want to be in the communities that we work with. So the way we are structured as a foundation is that Zimbabwe has got 10 provinces. So we've actually placed our offices in each and every one of those provinces. And what we say in the way we work, we say that we go where they are, we eat what they eat, we sleep where they sleep, we listen to them, and we co-create solutions. So that has been the focus of how we do our work. So, if you look at the way we are split economically, you'd find that in Zimbabwe, 67% of Zimbabwe is rural, and 67% of most of our beneficiaries are also rural. So there's that need, to make sure that, equity is always at the center of what we do. And, if you look into the pillars that we then focus on, we've got health as a pillar, for example. And in health, we've made sure that, the work we do in health is specific to each of the 10 provinces where we're working in. Latanya spoke around issues to do with maternal mortality, neonatal mortality. COVID placed us in that terrible situation where, immediately we saw that the gains we'd had in Zimbabwe over the last 40 years or so, if we did not do anything now, would have lost those gains. So through our structures of the 10 provinces, we then, use data to pinpoint the at-risk institutions, and together with partners, we then have gone into those institutions. On the one hand, to make sure that they're well equipped in terms of emergency-related obstetric material for them to deliver babies safely, give mothers an opportunity. And then on the other hand, we also realized that we need to do a lot of training, because a lot of mothers, especially in Africa, you'd find that it's the issue of referring them to central hospitals that cause a lot of mortality. So in our case, we wanted to make sure that we bring the skills right where the institutions are at. And we've also tapped into technology to make sure that, we do that. So that's sort of like how we've, sort of like democratized, our funding, our work to make sure that, we give as much equity as possible to all these communities. Thanks, Amruta.
Thank you. Thank you for your inspiring work. And, both you and Latanya spoke about sort of like the external facing role of the work that your organizations do. And one thing that has come up in the last 1 year is also the inequities internally in global health. And to ask a little more about that, we have a fire starter question from our audience. So I'd like to start Mariam Zamir's video from Village Reach, who will address all of you, and then we can sort of take it from there.
Hi, my name is Mariam Zamir. I work for Village Reach on Immunization Equity, a global health nonprofit, and I'm also an advisor for Women in Global Health Seattle. As an immigrant from Pakistan, person of color, and woman, I had to rebuild my career from scratch when I moved to the US. I'm so glad to see the conversation about decolonization, gender, and equity today. My question is, despite the commitment to equity, we know that institutional colonization and gender inequality is built in the very structures. For example, in many funding agencies and UN organizations, country national staff have different access to facilities, career growth, and security, or the top jobs are reserved for expats. Organizations advocate for equity, not realizing their entire top leadership are white men. In some ways, it's easier to change inequity in small organizations, but how do you undo structural racism, colonization, and inequity in large organizations where it is built in the very policies? Thank you.
So that is a really key question of, the moment that we're living in. And Latanya, would you like to answer that as someone from—
Of course, I'm chopping to the bit. Yeah, I do. Because it is important, and and this has been a journey. This is not COVID. This is over 2 decades now. A lot of what we were saying was, if we could build the capacity at the local level, then it would provide for a world where resources would go directly to those that are solving the problem. And so we've had, tons of work that has happened. We have brilliant organizations like Kennedy's that are out there doing this work. And as he says, sleeping with those that are most marginalized, but yet we still seem to have this, and I think it was a Devex article that laid this out pretty well around solution privilege, right? And so that people who are living in the global north and in their headquarters, wherever they exist, thinking, okay, well, here's a problem, I need to solve it, instead of involving the communities and those that are impacted to help solve those issues, and then providing them the resources, not just money, but all of the technical and innovations that we have to be able to support that work. And so you're only going to be able to do that, though, if the quote unquote solutions privilege disappears, and that the representation at the table also looks like it understands and has the experience of sleeping with, as I like the way Kennedy put that, with the communities who are infected. So there's a lot of work we have to do. I know Lois knows this very well, and she's been doing that with the Global Health Council, that not just representation at the table, as our colleague was mentioning in the question, but it is also about how to actually integrate that philosophy into the organizations. And so it's not a one-off, oh, we hired a DEI specialist and so, we'll get better, but it is actually talking fundamentally about how we have justice organizations and justice as a part of the work that we do every day. But would love to hear from you guys.
Yeah, the questioner, spoke to the power of small organizations, or at least that's the way I interpreted it. And maybe there was a word of caution there about, well, that doesn't apply to large organizations. In my experience, as LaTanya was saying, running Global Health Council, we are a small organization. We're tiny and mighty, I like to say, but we represent or include a range of major international institutions, right? Major INGOs, corporations, universities even. And so in our calls around democratizing global health, decolonizing global health, and really approaching our work with an anti-racist lens and really understanding our power and privilege, we brought these other large institutions to the table. So I wouldn't discount the power of the fire starter, of the group or of the individual, frankly, right? Who can call folks in and really say, okay, I might not have all this power, but the more we're doing that on an individual level, the more we are seeing those flames spark, I think the more it really will catch fire. And that's been my experience just in the past 6 months. Imagine what happens if that continues over the next year. So I'm really excited about what we could do with that kind of energy. And I would encourage people who are watching or elsewhere, who have been a part of this movement at a more local level to keep speaking up. I know it's exhausting. I've been tired too. But there are more of us out there who are making this happen. And the people up top, the people in power, not everyone, right? But enough of them are listening that I think we are going to, realize this change we want to see.
Right, and this is not something that is limited to just this industry, right? These conversations are happening everywhere, and it's a great call to action to speak up and, find your community, find the people who are in a similar boat as you, who have the same experiences as you. Kennedy, if I can just come to you and, can we talk about sort of, how these conversations translate on the ground, both in the work that you do, but also in the organization that, you're at?
Yeah, so there's been a lot of intentionality if I look at, our organization. So one of the things that we deliberately had to do in our organization is that we've got a pillar that we call the gender pillar, and it focuses on girl empowerment. And the reason is that, the first thing we wanted to make sure that we did is that the foundation had to actually show that it is being sensitive, to these issues. But not doing it because we wanted to tick a box, but doing it because of strategy. And maybe fortunately for us, even at the top level of our leadership, we're led by, a female, and we've got quite a strong, team of executives in our a strong female representation in our executive. That has also helped quite significantly. But then, what the girl empowerment pillar is doing in our organization is that when we do programming, when we're designing our programs, that pillar is making sure that there is intentionality, in the programming process so that by the time we're actually going into the communities, internally, we've already agreed that this is exactly how we're going to do this. And then when we then go and be design thinking with communities and all that, the process is such that everybody is aware that equity is something that we do not, just talk about, but equity is something that we actually live. And just to, give you some of the things that we do. So part of what we do is our foundation is that we do scholarships for education. And in there, we have a stipulated position that says that we have to have minimum 55% of our scholarships have got to be, the girl child. So there's that, and the reason is, to do with the issues to do with 6-7% of our population is rural. So already you're dealing with this, the higher part of your population being disadvantaged. And if the girl child is in there, they're even more disadvantaged. So it's something that we're actually doing deliberately. And when we go into partnerships, we also, try and enforce the same approach. Thanks, Amruta.
Right. Thank you so much. Unfortunately, we're almost running out of time. We have 1 minute, but I really appreciate the concept of intentionality and how sort of these inequities sort of layer upon each other. And it really takes the whole village. It takes the entire global development community to address each one of these. So if I could just come to you, Lois, for your last remarks. We have about 30 seconds each, and then we can go to the other two.
Yeah, sure. Just to ground this in something concrete for me, this concept or conversation around equity, we're in the middle of COVID where we are still seeing this play out, right? And so coming back to your first question, whether we're getting it right, the answer is not yet. We really need to ensure that these vaccines, for example, are distributed equitably all over the world if we're going to reach the end of this crisis, and also just do right by others.
Right, Latanya, can I come to you next?
Yeah, and I'll just add quickly that, shifting power and privilege is not an easy thing. Usually people who have power don't give it up, but it's so important that we do this in global health because it really is the cornerstone of everything else that we need to do to face equality in global health and other sectors as well. Thank you.
Thank you so much. Dr. Kennedy, if I could just come to you for a quick 10-second wrap.
For us, it's about collaboration with as many partners as possible in a very strategic way. I'm sure we'll be able to, see the needle move. Thank you very much, Amruta.
Thank you. And thank you so much, all of you. We've learned a lot today, and these are themes that we will keep exploring here at Devex. Please keep watching and keep reading us. Thank you so much.
The COVID-19 pandemic has fast-tracked innovation in digital health, as so many health services have moved online. And today we're going to be talking about the way that digital health partnerships have helped to maintain health delivery in low-resource settings during the past year of social distancing measures. What lessons can we leverage to ensure that digital health innovation advances rather than threatens global health equity moving forward? We'll learn about the Pfizer Foundation's Global Health Innovation Grants, which support community-based social enterprises that strengthen community health systems and use digital technology to facilitate improved care, particularly for hard-to-reach populations. One of those organizations is Living Goods, a social enterprise which we've featured here at Prescription for Progress before, that works in Kenya and Uganda, recruiting and training locals to become digitally enabled community health workers. I'm thrilled to be joined by Darren Back, Executive Director of the Pfizer Foundation, Ruth Ngechu, Deputy Country Director for Living Goods in Kenya, and Diana Nakalema, who has delivered basic health services in her community since 2016 with the support of Living Goods. So to start, I'd actually love to begin with Diana. Diana, when I received some information about all the services you provide, I thought, I have to list these at the outset. It's just amazing all that she does as a community health worker. But I thought better to hear from you. So can you tell us, Diana, a little bit more about your work? And let's start pre-COVID. Then we can get into the challenges of COVID-19. But what are the services you provide to your community on a day-to-day basis?
Okay, first of all, we treat children under 5 years. We first test for malaria. We treat diarrhea and also pneumonia. We make follow-ups of pregnant women. We also make up follow-ups of the newborns in the community, and we also refer For those clients whom we find that they have side effects, danger signs, refer to the health facilities for further medication.
And one of the things we're going to get into in this conversation is the way that the Smart Health app is a tool that actually enables you to do your work more effectively. But can you just tell us a little bit more about how you do all of this work in a digitally enabled way, as we talked about before, with the Smart Health app? How does that help you?
We are using the smartphone network, and of which we get a problem at times in synchronizing. At times, our data, it takes a lot of time to reach that data and also to synchronize. And also the air times at times is small, and the data is also less. We are using the app to help us to treat the children under 5 years. And this app is also helping us to assess the children in this era of COVID-19, of which it is helping us to reach our assessments to our supervisors. And also we can easily assess by phone, and also by phone. If you assess by phone, the app is also helping us to streamline the assessments on time, so that it can give us the easy flow of our work.
Thank you, Diana. So it sounds like the app presents some opportunities in terms of being able to assess information on the go, but also there are some challenges, as you mentioned earlier, with data. So we'll get back to some of those challenges as well. And Ruth, I'd love to hear from you about COVID-19, its impact on the work of community health workers, and what you're seeing on a country level. And then we'll bring Darren into the conversation to hear how the Pfizer Foundation is working with Living Goods on some of these challenges.
Thank you very much, Catherine. Just as you know, globally, the work of community health workers have been affected by COVID-19, and not only health workers, it is across the board for all healthcare workers. So we have seen need for continuity of care, well as also trying to control the spread, because everybody can actually be able to spread, including our healthcare providers who are the community health workers. So the Smart Health app has come in very timely in terms of supporting the continuity of healthcare service delivery. And as my colleague, I am a community health champion, so she's my colleague in the field, has indicated, the tool has really helped them when it comes to delivery of healthcare services. And one way that we have worked with them is as we try to protect them, we are also ensuring that they are able to provide those services. And one of the ways that you've done so is what we are calling the no-touch protocols. And the no-touch protocol is whereby the community health worker can be able to offer services, well as not coming in direct contact with the client. So from our end, as Living Goods, we have equipped them in a way that the digital tools are automated, and they are able to support the case management, case identification, and in a way that the protocols are standardized, and that reduces any guesswork that comes with paper-based system of working. To a greater extent, our community health workers have been able to use these tools to register mothers, as she has indicated, and support them remotely by following them up through phone calls and SMSs. And also, when it comes to assessment of the children under 5, they've been able to continue working and offering those services. Like in Kenya, I can tell you, we've had the COVID-19 has presented an opportunity where we have seen an increase. We have had a spike by 85% of the people that we are taking care of. We've seen an increase in demand and services that have been offered by the community health workers. We can attribute that to the fact that some of the clients were a bit worried about seeking services at the health facility. So our community health workers came in handy to support them, and also being that they can actually be able to get them at the time of need, they've really supported these households as we would envision. So using the digital tools and helping the communities, we've been able to ensure that we have delivered services remotely. And also, one of other thing is that when it comes to supervision, our supervisors have been able to follow up with the community health workers and ensure that we are maintaining the supervision levels that they need to be able to deliver. And that way, one of the ways that we've done so is through SMSs and even using things like WhatsApp groups where the people have been put together in a group and they're able to speak to their supervisors and to speak to each other. Then on the side of interruption of COVID transmission, we've been able to support the community health workers and the household through ensuring that they have what we call a daily symptom checking on for them to make sure that they are able to check themselves and for symptoms of COVID. And through it, we have had some few who have actually been able to be identified in time, and they went for COVID tests. Some of them tested positive, not very huge numbers, but at least through that protocol that we came up with, our staff and our community health workers do check themselves before they go out to the field to ensure that we are making sure that we don't become carriers of the virus as we offer the services. And the data that we are getting is also helping us to make decisions, not only us, because it is being transmitted to the government system, where we are making, we are helping in the decision making. And this is the COVID data for surveillance, and also the service delivery data for us to be able to see how we continuously support the community health volunteers, the way we call them in Kenya, community health workers, and also offer incentives for those who are working. We can actually be able to tell who is working and who is not working. Thank you very much.
Thank you, Ruth. That's really interesting to hear how the data is useful, not just in the hands of community health workers or in the hands of organizations like Living Goods, but actually for larger health services, for government knowledge of what's happening in the country. I think that's really, really a useful insight. So thank you for that. Darren, I want to bring you into this. I know you've seen some of this work up close in Kenya and Uganda, and I'd love to hear more about your view on the important role that digital tools can play for community health workers and the kind of support that the Pfizer Foundation is providing to Living Goods and to other organizations in this space who are not only working to ensure that services continue, that healthcare services continue, but that we don't have these huge health backslides in critical areas like maternal, newborn, and child health.
Sure, yeah, and thank you. So I've been, as you said, I've been fortunate enough to have the opportunity to visit Ruth and Diana in Kenya and see their work in action, and actually go out with community health workers as well as the team in Uganda. And it's truly incredible, and I think sort of not doing enough justice in terms of how you both described it thus far. I mean, the program addresses so many barriers, which I can only imagine are even more important now with regards to COVID. So just with the digital health platform itself, as Ruth and Diana have explained, you know, it not only provides the algorithms for providing direct care and linking communities to referral services if they need that, but there's the back end data as well, which goes both to the government, but then also for the supply chain within Living Goods. But also, from my perspective, what was so important as well is the trust and the respect. Now, when I was with Diana and we were visiting from house to house, it was so clear that every community member really did trust and value the expertise of the community healthcare workers and the advice that they were giving. And so I can only imagine that in these times of COVID, especially when there's so much misinformation around, that access point becomes even more critical. So there's the technology itself, but then there's also, you know, the trust and the respect and the access that that the community has to the community health workers. And so, as you said, we've in the Pfizer Foundation, we've certainly recognized the value of digital health technology. There, of course, has been a proliferation of digital health tools, and they've become even more important now in the world that we live in with pandemics. So Living Goods, we've supported through one of our programs, which we've been running for 5 years, which is called the Global Health Innovation Grants. And we have many partners across 16 countries, many of which are working directly in communities using digital technology in a similar way to Living Goods. And then more broadly, just recognizing the need for scale and for impact, we've actually entered into a partnership called the Health Worker Training Initiative. And that's in partnership with Living Goods, with Last Mile Health, the Gates Foundation, and then several other of the pharmaceutical peers, because we recognize that we need to really pull those resources together, learn very quickly about what works and what doesn't work, and then scale that so it can really provide quality health delivery.
I wanted to follow up on this healthcare worker training initiative. The goal is to provide access to healthcare for nearly 1.7 million people and advance progress toward universal health coverage. So I want to better understand, what are the opportunities and limitations of remotely training community health workers? So we've talked about digital as a tool for community health workers to go into communities, but now let's talk about digital as a tool to train community health workers. So anyone who wants to jump in, whether it's Diana, Ruth, or Darren, I'd love to hear your view on how does digital enable greater scale in training community health workers, but are there limitations when you take away that face-to-face training?
So I can jump in first,
Sure.
and obviously Ruth and Diana are the experts, but certainly from my vantage point, what I've seen is, and you're right, I mean, Catherine, nothing takes away the value and the impact of face-to-face training for sure, and it's very important. But in times like these with the pandemic, even more so, we need to provide rapid information, and that information oftentimes is changing. It's changing daily. And so the value there of digital tools is that you can provide that information in the hands of community health workers as quickly as possible. And the tools are tailored to really deliver that in the most appropriate way for that particular organization, those particular community health workers, and then they can deter how to deliver that information and use that within their communities. So that's what we've seen. I think that really underpins the idea of scale, right? Is that you really can reach so many community health workers, and as you said, through the partnership that we have on running, the hope is to train 2,500 healthcare workers to reach 1.7 million people over the next 3 years.
Ruth, I saw you might want to jump in on that as well, just in terms of opportunities, but also challenges when it comes to remote training.
Yes, thank you. In addition to what he has just indicated, the platform provides for self-paced learning, where the learners can actually be able to interact with the platform at their own pace. And like in the physical classroom, where you don't know when to ask questions, and for the slow learners it becomes a challenge for them. But now this is so contextual that I can be able to pace myself depending on my understanding, and it is contextual and customized. Then the other thing is that it can enhance performance management because of the real time. You can actually be able to evaluate the learners real time as they learn, and you are able to institute mentorship for those who are slow or those who have challenges. It is easy to monitor and evaluate whether you are impacting knowledge or not. And then it has also increased the peer-to-peer learning and coaching, because I can actually be able to interact with my peers and ask questions without really fearing what other people will think about me, because I can reach out to Diana and ask a question. So it is really, it has a lot of advantages, and I think the COVID situation has really brought about very good innovations in the way we are going to continue doing our training of the community health workers. And just to reiterate, the speed at which you're able to intervene and give messages, and like when you have people together to be able to train them.
Thank you, Ruth. I wanted to bring Diana into this. Diana, I'm curious, in what ways are health workers like yourself involved in the design of these tools? I'm curious if your input has been a part of the process, or how have these tools kind of come onto your radar? Were they just presented as tools you can use, or have you been able to give some thoughts as to how they might work better?
Me and other community health workers, we make focus group discussions. After making focus group discussions, our supervisors come and they interrupt, they observe. After observing, they go and take back the feedback, of which feedback can help us to design other ways of making our work easy, and which also helps our work to run on smoothly, as to be fair in living goods, so as we can design and make our work to be smoothly. Yes.
That's really great to hear that feedback is part of the process. So thanks for sharing that. When we opened up this conversation, we talked about reaching the last mile. And I really want to narrow in on that challenge and the role that digital can play. So Ruth, maybe I'll go to you on this. And you gave us a bit of a preview, but maybe if you can provide some specific examples of some of the challenges of reaching the last mile and the role that digital has played in helping living goods address that challenge. Can you just give us that view on a country level?
Thank you. I can give examples from Kenya where we are working in different contexts. We have a county that is in a nomadic context. And for you to reach the households, maybe 2 households, you have to travel several kilometers, and depending on the needs, where the needs is. But with the digital tool, actually you can reach so many clients at the same time, because you don't have to go to travel long distance or walk long distance to reach your clients. And this has really improved on how efficient our community health workers are being able to do the work. And as I said, we've had a spike on service delivery that is being offered by the community health workers, almost doubling the efforts that we had last year, courtesy of the use of the digital tools. The other thing is that with the speed at which you are able to get data, and more so in responding to COVID-19, and the example that I've given of self-assessment for our staff and the community health workers, and being able to identify, because they've been trained on what the checklist on what to check out for. We've been able to identify cases like when we want to do trainings, this trainer cannot go out because of the challenge that they have, and maybe when they test, they realize that maybe they have been infected, and that way we have actually been able to curtail the spread, given that our community, those who have been found to be positive, they've been able to abstain from mingling with other community health workers or other trainers, and that way we have curtailed the spread. And lastly, the digital tools have helped us in terms of authenticating the work of the community health workers. Real-time data, you can be able to tell who is working and who is not working. And it goes with, we have set KPIs for them. You're able to see and track, they being able to hit those KPIs. For those who are not being able, you're able to support them if they need any support in terms of mentorship. You're able to do it in a speedy way, other than if you did have the digital tools. And as I've said, the information that generate, or the data you generate, actually, since it is generated in a timely way, it is supporting in decision making. And we have seen when it comes to like qualification of products that they need, it has really improved, even from our side and the side of the government, for the communities that we're getting from the government. Thank you.
It's just so interesting speaking with you all at this moment in time, because for a few years now, I've written about again, living goods and last mile health, and their whole vision of a digitally enabled community health workforce. And now just to see how essential that's been in the past year and hear about the opportunities and challenges, it's really fascinating. Darren, I'm wondering if you can help put this partnership into a larger context of some of the work you're doing this year. And what are you learning in terms of the role of digital in continuing health services, the role of digital in ensuring that we don't have these horrible health backslides that are real risks this year, and the role of digital in universal healthcare. How does this living goods partnership fit into the larger context of the way you partner and the way you see digital?
Yep, for sure. Well, I mean, I think you made a very important point, Catherine, in terms of digital is really enabling response that we're seeing at the moment, both to COVID, but also to ensuring the continued service of basic and essential health services. And really that is key. I mean, I saw data last year that estimates of up to 6,000 children dying a day now because of disruptions to lack of access to the vaccine programs. And we saw with Ebola, right, in West Africa in 2014, 2015, is that really what's key is that absorptive capacity of the healthcare system to be able to deal with the shocks with epidemics or pandemics like we're seeing now. And I think digital tools are really one of those solutions to be able to do that. And I think Living Goods is a perfect example of that on all areas, both in terms of the delivery of quality services, but then the back end, the data that's coming through to inform health delivery as well, and what are some of the sort of the key barriers that still need to be addressed. I think more broadly, this has now really challenged the global health community. And it's an incredible opportunity. It's a really important moment in time that we can't miss. And so we've all been challenged to think very differently around what do partnerships look like, and really how do we play to our strengths? I mean, in this situation, we all have the same goal, which is ensuring that we get quality health services to people who need them. But within each context, it's very, very different. And as an organization like Pfizer and the Pfizer Foundation, we have a lot of resources available to us. But then the insights and tools that are available to Living Goods are very different, as are from many multilateral organizations as well. And so I think what we're seeing now is this agreement that we all need to work together in similar and also explore very different ways of working, and non-traditional ways as well. I mean, I recently joined the board of the Bay Area Global Health Alliance in San Francisco, and really that was the rationale, is because we recognize that global health barriers cannot be addressed alone, and we all have to think very, very differently. And the tech community in the Bay Area plays a huge role in that. And so how can we bring those forces together in terms of the skills of NGOs, the pharmaceutical sector, and then the tech and digital sector as well? And so I'm really hopeful that we'll continue to see this growth, and we'll continue to see this sort of very quick learning, quick application in terms of addressing the barriers that we see.
Thank you, Darren. That's a beautiful articulation for the reason the Bay Area Global Health Alliance exists, and the reason that this Prescription for Progress event takes place as well, is bringing people together across sectors to advance global health. So thank you. We have just a couple minutes left, as much as I'd love to continue the conversation. Would love to go back to each of you for very quick reflections. Something you heard another panelist say that you'd like to reiterate, or a final call to action for our audience. I'll share from my end. It was trust. When Darren mentioned trust and how do we play to our strengths, I think that is something community health workers have in their communities that is unique and powerful, and something to be leveraged. And digital can help, but trust is essential. What about reflections from you all? Diana, Ruth, do you want to jump in? Just a quick thought or a quick message for our audience?
Yes, I can come in and just what Diana said, the power of digital tool at the hearts of the community health workers, what it can be able to help them do, and like when they don't have these tools. And one of the things that came out is the standardization of what service package they are offering. That leads to a standardized approach and also standard quality care.
Thank you, Ruth.
And then from me, I mean, partnerships obviously key. It's critical and fundamental to all of this and everything that we've done within the Pfizer Foundation. But at this particular conversation, what really stands out to me is Ruth talking about the back end, the data, and how Living Goods is now using that in a surveillance capacity. And we really need to focus in on that, especially now with the pandemic. Is we have to think innovatively about how can we get surveillance data through some of these digital tools that's really going to optimize service delivery that organizations like Living Goods and governments in terms of how they're using that data.
Well, Darren, Ruth, Diana, thank you all so much for your time. And I'll say, while I wish we could be together in person, one of the really powerful things about the virtual platform and digital tools is that we can all be here together in conversation from our respective geographies.
Thank you. We thank Living Goods so much as community health workers. We also thank you for the PPEs that they have managed to give us, which help us in the community. We also thank for the funds because they have helped us to identify COVID patients in the communities and also making referrals to the health facilities. Thank you very much.
And thank you, Diana and Ruth. I think there's a lot that we can learn from the work that you're doing here in the US and in other countries all around the world. So thank you for the incredible work you provide.
Well, I want to welcome everyone back here to Prescription for Progress. This is Devex's flagship event on the future of global health, and we're so delighted to have all of you with us, joining us from around the world, and really for a very special session, maybe the highlight of this event for me, just getting to sit and speak with Heidi Larson or with Peter Piot individually would be exciting, but getting them both here together, a virus-fighting duo, as they are widely known around the world, it's just great to have you both. So thank you for taking the time to be here. I'll just say a couple of quick words about you. I think people who are here know you both quite well, but of course, Peter maybe is most famous for back in 1976 co-discovering the Ebola virus, identifying it, and then spent a career fighting HIV as the founding executive director at UNAIDS and many years as a UN Undersecretary General. He's now, of course, the director of the London School for Hygiene and Tropical Medicine, and has himself survived COVID-19 and is a special advisor now to the European Commission's president on this virus. So really a remarkable leader in this space. It's fantastic to have you here. And then Heidi Larson is an anthropologist, also affiliated with the London School of Hygiene and Tropical Medicine, and leads a center there, which is focused on vaccine hesitancy. It's called the Vaccine Confidence Project. It's a WHO Center of Excellence, and has really become a leading expert in the world on this growing, emerging, maybe fully emerged issue of vaccine hesitancy, certainly very salient for the times that we're in now as we read everyday news about the latest vaccine. I'm so delighted to have both of you here for this discussion. Thank you. And maybe I can just begin with you, Peter. You know, we're almost at the 1-year anniversary of the WHO declaring this a global pandemic. And so I wonder, as you think about where we are, how this moment maybe is a bit different than where we were in the fight against it and where we're headed. How do you sort of describe the moment that we're in today in the fight against COVID-19?
Yeah. Hi, Raj. Nice to see you again. Well, I think we are kind of getting to the end of the beginning, in a sense. On the one hand, we had, during the current wave, more people dying than even in the beginning, at the beginning of the epidemic. And it seems as if we hadn't learned much in terms of societal response. On the other hand, the biggest difference is that today we have vaccines. Vaccines are there, but they're not available for everybody, but that's a matter of time, I hope, and we have to do everything we can to, ensure equitable access across the world, because otherwise we're all in trouble. If not everybody has access to vaccine, we'll all suffer. Plus, what is also new but not unexpected for us virologists is that there are these so-called variants, mutations. That's what viruses do, and these are new challenges. But I think we now can at least plan for a return to more or less normal, although I don't think we should do that too soon, too rapidly, because then we are guaranteed going straight into another big wave with lots of deaths.
I want to dig into lots of that, including the variants, the emergence of variants. But Heidi, just the same question to you. Generally, how do you see the moment we're in now, a year into the declaration of the global pandemic?
If last year was the year of immediate control, this is the year of the vaccine. I mean, 2021, and we're just at the beginning. This is going to be an incredibly important year for vaccines in general, for the relationship with publics, and it's a huge opportunity to get it right. Yeah, it's the year of the vaccine, I would say, or vaccines, making
I was
it
going to
even
say,
more
it's interesting when you say the vaccine, right? Because for so many other viruses, we are used to going and getting the vaccine. We don't really think too much about the manufacturer or the type, but this is a very unique case where the whole world is very tuned in to the many vaccine candidates that were in the pipeline, then the ones that have gotten emergency authorizations, the ones that are available in their country or in their clinical setting. It's starting to be, it's a different scenario. And I hear people talking about which vaccine are you getting and which one will I get? And in fact, we have now the case, a really important case in South Africa with their variant, possibly from one small study not being effectively dealt with by the AstraZeneca Oxford vaccine. I wonder if, Peter, maybe you and Heidi both want to weigh in on this issue of the emergence of the variants, the battle against those variants with vaccines, our limited knowledge and understanding as we go through, and how to approach this.
Yeah, it's indeed new, but one thing that I think we should also realize is that we're in for the long haul here. We have to prepare for societies living with COVID. I know that some people talk about zero COVID, but that's an illusion. I mean, only one virus that infects humans has been eradicated, eliminated, and that's smallpox. And that took a major effort. And maybe we'll get there over time, but I don't think so. This is a very smart virus. It mutates all the time. So that long-term strategy, we need to look at it right now while we're dealing with the crisis. And the crisis is, among other things, because of the appearance of variants. And the more we sequence, the more we will find, because that's what viruses do, they mutate. And the biggest fear, of course, is that these new variants will be more transmissible, and that's already proven for example, the so-called British variants. They have impossible names, B1117, or particularly whether they make vaccines ineffective. And fortunately, up to now, there's at least from particularly the South African one, from a trial with the Janssen, the J&J vaccine, that showed that it was less effective for mild disease, but in terms of preventing severe disease, hospitalization, and death, it was as effective as the trials in the US. And that's what we're really after with vaccines, preventing people from getting hospitalized and keeping them out of the hospital, keeping them from dying. That's the #1 priority. We have to prove this now for other vaccines as well. So it won't be an all or nothing thing, but what's key is that we now prepare for the eventuality that variants will, just make vaccines ineffective. So that's now another race against the virus.
So do you expect then we're seeing a situation, and maybe either of you, Heidi, too, you want to jump in on this, where we'll likely all be getting, when we have access, depending on our country, get access to a vaccine and then getting boosters maybe in the first year, and then in the future getting 1 or 2 vaccine shots every year kind of for the rest of our lives? Is that something we sort of should expect to happen? It certainly brings in the question of vaccine hesitancy as a public health issue at a much higher level, if you think of it in those terms.
Well, I mean, I think it's another uncertainty that feeds into the hesitancy issue. And I think part of what's allowed the hesitancy to thrive and the anxiety to thrive so much is the level of uncertainty. Peter's better to speak about the possibility of boosters, and I know that that's certainly been in discussion, but I think people will accept boosters if they need them. What people are uncomfortable with is the constant changing, the uncertainty, the not knowing, is it worth the risk if it's not even the right one? So I think it's really, we underestimate the ability of publics to get on board. But there's some basic things they need, which is 1, trust, 2, consistency, and then some evidence that it's actually making a difference.
Right, and uncertainty is kind of part of, it's the name of the game when you're fighting a novel virus, right? And we're developing new vaccines. There's going to be uncertainty, but I guess how we manage that is really key here. And I think about the case of South Africa in particular, the country having to make this decision. How do you feel about that, Peter? You know, I know the African CDC has said, no, we should go forward with the Oxford AstraZeneca vaccine. In other countries that have already made contracts to buy it and receive it, they should. It sounds like maybe from a public health standpoint, the issue is just get as many people vaccinated with any approved vaccine as quickly as we can. Is that the way to think about this?
Oh, I was very impressed by the very rational decision-making in South Africa. I mean, one of the mantras of many governments have been during this epidemic, we follow the science. Whether they do that or not, that's another question. That was very variable. But in South Africa, when it was shown that the AstraZeneca Oxford vaccine only protect about 10% protection, that's basically not much against this variant, then they said, we're not going to use that. We're going to go for the Janssen vaccine, which showed us very high protection. It may still work, the AstraZeneca vaccine, for severe illness and deaths, but there are no data. And I totally endorse what the Africa CDC did. So I just can't understand why WHO's SAGE committee recommended the AstraZeneca vaccine also for countries where the South African variant is prevalent. I mean, I certainly supported it's a very good vaccine, the rest of the world, but there are no data. And so at the moment, I would say that where we're going to is probably not an annual type of booster. You never know. But I would expect that as more and more people are vaccinated, plus all the ones that are not vaccinated, there will be more variants coming up. But it may be a defined spectrum. So let's say that there are 4 or 5 variants we know that are really problematic for vaccine protection. And then companies can develop vaccines that will protect against these ones. That's not impossible whatsoever. That's technically possible. It's the manufacturing, it's the approval. And then we could go indeed to a system where now and then we need a booster, because we also don't know how long is the protection going to last. Is this 1 year, 5 years? For measles, it's lifelong. All unknowns, and managing uncertainty, as you said, has been probably the biggest challenge for individuals, for societies, for decision makers. And we really have to learn while we're sailing, or racing is probably a better word.
Heidi, is the issue of vaccine hesitancy here a rich country problem? Is hesitancy an issue we need to worry about in the global health community too, when we think of low income, low resource settings? Or is it really a rich country problem in France, in the US, the UK, et cetera?
Oh, it's totally global. It just plays itself. I mean, I've just finished a 15-country study with Africa CDC across the continent, and there's some serious issues of refusal and distrust. And it not everywhere, but and even aside from COVID, we've seen this with other vaccines. It's very much about relationship with government. It's about trust. If you're doing well with your government, you're going to be much more open to these things. But there's a lot of factors, but it's not at all unique to the wealthier countries. And I think that's been a bit of a surprise to the global health community to see. It emerges in different ways. It's very unique, even the difference issues with different vaccines.
And we've just got a couple of minutes left, but briefly, Heidi, to the global health community, what should we be doing, or at least thinking differently about this? I know your center is partnered with Facebook, and there's always this tension between social media maybe helping to fuel these things, but also possibly being part of the solution. How should organizations that work in global health be thinking about this differently?
I think we're always quick to kind of take the, push it out there approach, and they'll come get it, and then we'll deal with the hard stuff when we get there. We know where the issues are in the population around vaccines. That's reasonably predictable, but I think we do need to keep surveying and listening. But I think we should start there first, or at least start there early, and we should be out in the communities. We know we're going to face challenges, listening to them, engaging them, making them feel like actually you care about what they think. If we don't get that engagement going now, before these vaccines start rolling out, we're going to miss a huge, important opportunity.
And Peter, just as we wrap up, is this the virus, is COVID-19 the thing that changes our thinking as a global health community? We kind of thought maybe Ebola in West Africa would do it, and people would care more about pandemic preparedness, and countries would invest more and see a minimum health system we all need to have. That didn't really happen. Do you think this will do it? Do you expect to see or want to see something change in the global health kind of dialogue coming out of this?
If this pandemic doesn't do it for global health and for, actually, I would say also putting equitable partnerships on the table, then I don't know what it will do. One, it shows clearly that health is truly global. Two, this was not an epidemic that, when you think from Europe, that came out of Africa like Ebola. No, it is the other way around. The first cases came from Europe, came from Asia. I think this needs to lead to a new world order in terms of health, and that we need to invest in infrastructure, in systems for epidemic awareness and preparedness, but also the health systems in these countries that are less fortunate than the high-income countries. But even high-income countries, UK and US haven't done exactly a great job. UK is doing a good job with vaccination, but now we need to vaccinate the whole world. That's key, otherwise nobody will be safe. And secondly, we should not relax too fast with all the measures, because otherwise we'll be in trouble again. And thirdly, we need to prepare for the long term, for the next pandemic, and invest in it. It's not going to be cheap, but it's much cheaper than having a crisis at a global scale as we have now.
Well, let's see what comes out of this. I know the community people watching this and part of Prescription for Progress are the very people who are at the forefront of trying to shape this new reality. And it's been a real pleasure to hear from both of you and give us some inspiration and some guiding light as we go forward. I'm glad you're well, Peter, and it's really nice to see you both. Thank you for being here. Well, I want to thank Peter and Heidi for that fantastic discussion. And it's so great, again, to be with all of you here at Prescription for Progress. We've got an exciting internal announcement, and I want to, for that, bring Catherine Cheney back to the stage. Catherine, please join me. Nice to see you.
You too, Raj.
So the day's going great. I'm loving this event and this focus on global health. Tell us a little bit more about what's in store, what we're here to announce at Devex.
Sure. Well, I know my colleagues will be sharing more in just a moment, but basically you can count on this conversation continuing, not only through our coverage, but for a series of upcoming events. We are going to be investing even further in our global health coverage with this focus on best practices. What lessons can we learn from this critical moment and apply them moving forward?
Well, let's invite those colleagues in, because it'd be great to hear from them directly. And we can do that since we're virtual. So Amruta Biatnal, Rumbi Chakamba, Jenny Ravello, please turn on your cameras. You're, I think, well known to our audience for your bylines and your great reporting around the world. Amruta, maybe you can just give us a sense of what our new focus on global health is really all about.
Yeah, thank you, Raj. As you mentioned, we've been covering global health for a while here at Devex. Our COVID-19 coverage has been excellent. Our reporters from around the world have been on every sort of angle of the story. And what we want to be doing next is to provide a dedicated newsletter for our audience where you can catch every new update and every new development in the world of global health, which goes beyond COVID-19, and really look at how these decisions are made and how they affect people on the ground. I'm really looking forward to, reporting from more freelancers. As Catherine mentioned, we're putting more resources into this. We're really looking at, where the gaps are. And I'm really excited to be part of this new initiative.
Fantastic. Jenny?
Yeah, just as Amruta mentioned, I'm really excited to have this newsletter. We've been covering global health for the longest time before COVID. During COVID, post-COVID, we'll be continuing that, looking at lessons and how they are being implemented or they not being implemented on the ground. So I'm just really excited and invite everyone to subscribe to our newsletter. And so you can have, all the global health stories that were coming out, you can all read them.
Absolutely. And Rumbi?
So in addition to our excellent COVID-19 coverage, we'll also be digging a little bit deeper, reporting a little bit more on underreported diseases, essential to access to essential healthcare services, and we'll also be just checking in to see if those lessons from COVID were actually learned. So this is a fantastic time to actually sign up for that newsletter.
It is very exciting. And I think Prescription for Progress, Catherine's a perfect place to announce it. It's actually going to happen. The new newsletter and the series of events and our new focus on global health will be starting on March 11th, which is the 1-year anniversary of when the WHO declared COVID-19 a global pandemic. A tragic moment, but also maybe a hopeful one as we look to a new future in global health. Well, welcome back to Prescription for Progress. Hello, everyone. I'm Raj Kumar, the President and Editor-in-Chief of Devex, and excited to start a special session in partnership with GSK, where we've got an exciting announcement you're going to be hearing for the first time. And before we get into that, let me just mention who you're seeing on the screen here with me. We've got Dr. Pauline Williams, who heads up the research and development area in global health at GSK. She's a senior vice president at the company and is focused on malaria and TB and other disease areas that are so impactful in the global south. And we've got Dr. Harmony Garjas, who's with Vive Healthcare, which really is a company that focuses on HIV treatments, and they are majority owned by GSK, work in partnership with GSK. And so we're going to have a discussion about some of the disease areas that we're talking about a lot today at Prescription for Progress that affect many millions of people in many low-income and fragile countries that may have been off the front pages a bit this year. And we're going to get into this announcement that I think you're all going to find very interesting. So to begin, I'm pleased to queue up a video here from our friend, Dr. Gitinji Gitahi, the CEO of AMREF Health Africa.
So this is the partnership that we are working on with GlaxoSmithKline, which is going to be launched in February. And it is aimed at, one, reducing the burden of disease and death, and also reversing the negative effects we've seen of the COVID-19 pandemic, and ensuring that we can actually start to accelerate the gains that we were having before. This is the partnership that we are building on and repurposing and recreating with our partner GlaxoSmithKline. So AMREF Health Africa and GSK have been working for over 30 years, and we've been working in different areas of the health sector. We've been working on areas of innovation, innovating new areas, new ways of doing things. We've been working together on community engagement, looking at what are those barriers that communities face that we need to help them overcome, or we work together with the communities to overcome those barriers. We've also been working on areas of training health workers and capacitating health workers. And now we are looking at this partnership in terms of how do we leverage the more than 30 years of work to actually build robust cross-sectional and kind of horizontal changes to the health system to overcome the challenges that malaria and TB bring to the communities as a critical burden to achieving sustainable, lasting health change for communities. So we are looking at how do we leverage our various strengths. We leverage the community engagement strength that AMREF has, and leverage the research and development strengths of GlaxoSmithKline to bring to bear our interventions for TB and malaria, specifically in these two high-burden countries of Kenya and Ethiopia.
So Pauline, we just heard from Gitinji a little bit about why you're engaged in this partnership, but maybe you can tell us a bit more about what the partnership actually is. What is GSK doing with AMREF, and why is it so relevant at this moment?
Thanks, Raj. Well, I mean, it's great to use this Prescription for Progress platform to launch this really exciting partnership. And as Dr. Gitari said, this builds on decades of experience that we've had with GSK partnering with AMREF, and a really fruitful partnership. But this is really specific and timely, as you said, in terms of recognizing the impact that COVID-19 has had on really setting back the progress that's been made in really responding to the challenge of malaria and TB. It's a program that is over 2 years. It's based in specific regions in Kenya and Ethiopia. And it's community driven. It's very much aligned with local healthcare policy, so that makes it sustainable. But it really is looking at equipping communities to really recognize signs and symptoms of disease, and so promoting healthcare seeking behavior, but then a very dedicated healthcare worker training program to give those healthcare workers the tools that they need to really support surveillance of disease at a broader level, but also specific signal detection and symptoms so that they can provide the appropriate diagnosis and treatment. And it's designed to be scalable. We see that this is an opportunity not just to expand across regions, but also across diseases as well.
All right, I want to dig a bit more into the partnership, how it works, because it sounds like you're getting to a key challenge that is faced in many healthcare settings around the world. If you don't identify the patient early, diagnose early, there's no way to get them into a care setting and to ensure they're getting the care that they need. But maybe we can bring Harmony, you into the discussion. You're the chief medical officer at ViiV, and you've got a long history of really doing drug development and clinical trials. So you're very much as well, like Pauline, on the R&D side of things. And yet we've all learned in the pharmaceutical industry and beyond that it's not just about developing something, an intervention, a medical device, a drug. It's about how do you deliver it to people. So what are the gaps that COVID-19 has created in the areas you work in HIV or malaria, TB? I mean, we can all get into that and then think about how this partnership helps address that.
Yeah, it's a really important point, Raj, and it actually resonates with one of the sayings I use with my team all the time, which is that you can discover and develop the best medicine in the world, right? But if you can't get it to the people who need it, we haven't done our job. So, you know, what COVID-19 has brought home, I think, is how fragile some of our healthcare systems are in many parts of the world. And we've definitely seen an impact of COVID-19 across the HIV community. So we've seen the impact on people living with HIV. We've seen the challenges that healthcare professionals have who are trying to administer the care, ensuring their patients can get access to antiretroviral therapy. And we've certainly seen the impact from a clinical trial perspective as well. But
and a lot of this is because you've had shutdowns, right? You've had economic shutdowns, or people can't get to their facilities where they might normally get medicine, or maybe the economy has been hit so hard that they don't have access to the basic nutrition they need to go along with a medical regimen. Is that right? What do you see as some of the ways the pandemic has actually impacted people living with HIV?
Yeah, all of the above, everything you've highlighted, Raj. So I was just on a call last week with one of our partners, an Italian NGO known as Quam, that works for in capacity building, right, with some of our physicians in Mozambique, in Beira, who has been hit by natural disasters as well as COVID. And it really brought all of this to life. So it's been incredible, though. What's been so inspiring is seeing what they've been able to do to overcome those barriers. So using new innovative technologies, mobile phone technologies, to make sure people know where to go to access their antiretroviral medicines, coming up with creative solutions for how those can get delivered. And from our perspective, in terms of clinical trial supply, we've been making that a primary focus. And I'm proud to say we didn't have a single stock out of any of our clinical trial supplies in light of this, but it's only because of the dedication and the extra effort by our partners on the ground who have really been able to help us mobilize all the resources required to meet those needs.
Yeah, you were talking about how clinical trials can be affected. I was trying to think of, well, what are the many ways? And that's certainly one, right? If the supply chain of the drug itself gets interrupted in some way, you interrupt the clinical trial, maybe you can't use that data, and it could be a really significant challenge and delay to developing a new therapy. Have you found that during the pandemic, because of all the disruptions, the many reasons we've gotten into a bit of, that patients who contract malaria or TB don't get care as early as they might have before this pandemic? Is care being delayed because they don't go to the medical facility early enough? What are you finding in those two disease areas?
Well, I mean, from the R&D side, definitely we've seen that we've got a study ongoing in TB in South Africa, and that has been the case where that study has been significantly delayed for the reasons that you just articulated. And I think, it's very regional. We can't make gross generalizations, but I think we certainly are seeing examples where lockdown is inevitably restricting people's movement, and that's got an impact on transmission within the household for TB, for example, and perhaps a reticence then to leave and travel to get healthcare interventions, and then the healthcare professionals themselves being redirected very much towards COVID response. And so that in turn is having an impact, and supply chain disruption in cases for diagnostics and treatment as well. So it's really a big impact. And I've just been looking at some modeling work that's been done by Stop TB and USAID with Imperial that has really shown some quite concerning projections for even the impact of a short-term lockdown. And they've looked at Ukraine, India, and Kenya, with assuming a pretty rapid return to steady state. The impact over the next 5 years on case rates and excess mortality is really quite stark. And so I think, now is the time to really introduce or continue the momentum that we have in addressing these diseases.
Yeah, we've been covering this a lot at Devex, that there's this kind of silent wave that's going to come that we're not paying a lot of attention to now, but we're not seeing it too much in the data yet. But the modelers suggest it will be here as we kind of ramp down on the coronavirus in many parts of the world. You'll see, potentially many of these untreated health conditions grow, unfortunately, with a huge burden. It seems like, listening to both of you, that partnerships, this one in particular, but maybe others that you're engaged in, I'm just reading that you've got a partnership with ViiV and with CHAI and UnitAid on accelerating the development and availability of optimal HIV treatments for children and adolescents. It sounds like partnerships maybe has become a more important thing for you because of the pandemic. Has your perspective on the idea of partnering changed in the last year and a half or so? Maybe Harmony, you want to jump in?
Well, I'll start, Raj. I mean, partnerships for ViiV is really at the core of who we are. As a company, we're a joint venture with GSK as a majority shareholder, but with 2 other partners as well. And so it's really at the heart of who we are as a company. And we've always leveraged our partners very heavily. We have over 50 organizations we partner with, whether it's in the research and development space through various academic partnerships and academic organizations, whether it's in the community space, through other partners in terms of helping us with generic preparations and getting access, and even in the policy space as well. So we've always levered partnerships very heavily from a ViiV perspective. But what I believe COVID has done is just galvanize that, right? It's just shown us that this is so important to everyone, especially when you're talking about the burden of HIV. It requires partnerships. One company, one organization cannot do this alone. And when you layer COVID on top of that, it's just really brought to light, I think, for the global community, how important these partnerships can be. And to highlight it from the HIV perspective, similar to what Pauline said, many of the global HIV organizations have done modeling and calculations showing that COVID has definitely impacted who's getting tested. We always struggle with that anyway, and this has made that challenge even greater. And who's accessing antiretroviral therapies. And they've projected it both in terms of what that means for adults and adult mortality, as well as what that means in terms of mothers passing HIV on to their children as well. And some of the statistics are staggering. If you look at the percentage increase that they're projecting out in these populations, it's quite striking.
Yeah, and we know that the inequalities that existed before the pandemic, they're going to get exacerbated dramatically whenever you have a situation like this. And so the people with the least access, they're going to do the worst. And if we don't do something now, and partnerships like this are a part of this, to address it, we will be dealing with this in the statistics and in the human tragedy in the years to come. Pauline, we only have a minute left, but I want to turn to you for a sense of a call to action maybe for this audience here following us around the world for our very future-oriented event here, Prescription for Progress. What do you want people to take away from your announcement and from our conversation today?
Well, I mean, I think it's just to build on the point that you've just discussed. I mean, partnerships are absolutely critical. We've seen some really non-obvious partnerships created through COVID-19, and let's build on those, and let's really think about how we can work across sectors to really address public health challenges moving forwards.
Yeah, and it's interesting for me to hear that coming from you, Pauline. You lead a team of scientists, of innovators. Your people were working in labs, and yet now we realize that in the global health community, it's everyone from that scientist all the way to a community healthcare worker. We've got to be aligned. We have to have one strategy, or it doesn't work, right? We're only as strong as the weakest part of our health systems. And certainly, if COVID has taught us anything, I think it's taught us that. It's great to be with both of you. Thank you for bringing this announcement to the Devex stage here at Prescription for Progress, and we wish you well with it.
Thank you very much.
Appreciate the opportunity, Raj.
The COVID-19 pandemic has highlighted the linkages between the health of humans, animals, and the planet. So how can the global health community take on these interconnected challenges? We'll hear from leaders in Planetary Health and One Health about opportunities for collaboration. First, I'd love to welcome Sam Myers, Principal Research Scientist at the Harvard School of Public Health. He also directs the Planetary Health Alliance, which is a consortium of organizations around the world committed to understanding and addressing the health impacts of environmental change. Sam?
So to me, the arc of the planetary health narrative is that there's just been this explosion in as a result of sort of scientific and technological developments, this explosion in the size of humanity's total ecological footprint. And people have called this the Great Acceleration. But if you go back and you look at sort of curves of human consumption over time globally, you see these really kind of astonishing kind of exponential curves that started in around 1950 and just were, have accelerated since. And whether you're talking about, proliferation of motor vehicles or appropriation of fresh water or exploitation of fisheries or production of paper or plastics or energy use, they all have that same shape. And if you look at impacts on natural systems, they also all have that same shape, where we've had these really outsized impacts in terms of biodiversity loss, chopping down forests, adding carbon to the atmosphere, these big scale impacts. And they all look really similar because of this sort of fundamental underlying trend, which is that the human population's been growing really fast and per capita GDP has been growing even faster. So when you multiply those to get total world GDP, it's essentially a vertical line over the last few decades. So it's hard to overstate, right, the scale that our ecological footprint is now taking on the earth. And I don't think that many people in your audience will really grasp that scale. So, 40% of the terrestrial land surface is being used for croplands and pasture. We're appropriating half the accessible fresh water on the planet, mostly for irrigating our crops. We've dammed 62% of the world's rivers. We've cut down half of the tropical and temperate forests. If you look at biomass of mammals on the planet, 36% of total biomass of all mammals on the planet is us. 60% is our livestock. 4% of the mammals on the planet are actually wild mammals. We're driving species extinct at 1,000 times the baseline rate. There are about a million species facing extinction, many in the next decade. So it's hard to overstate the way that we're sort of crowding out life on the planet and transforming these systems. And it's the urgency of that moment, of those exponential curves that we're sitting on top of, that explains the emergence of the field of planetary health right now. And it's the recognition that not only is our house sort of on fire, right, that our natural systems are really kind of crumbling under the weight of our ecological footprint, but we're in the house, right? And there aren't any exits, right? We don't have another planet to go to. So it's this recognition that this isn't just a matter of an ecological crisis. You don't have to be a tree hugger. You don't have to be worried about the polar bears to be concerned, because it's actually what we're learning from planetary health science and research is that there are enormous impacts on our own health and well-being in every dimension of health. And there's a rich, we just published this book, there's a rich sort of body of evidence across each one of those dimensions. So the narrative is huge sort of ballooning in the footprint, rapid changes in natural systems, recognition that those changes actually represent clear and urgent threats to human health. And then the sort of, okay, that's the diagnosis. What's the treatment? And the treatment, is what the World Economic Forum is calling the Great Reset, what we've been calling the Great Transition, what indigenous communities have been calling the Great Turning, what Europe and President Biden are calling Build Back Better, but it's all the same thing, which is we've got to change the trajectory that we're on. We need to live differently, and that means across every sort of dimension of activity. And so that's where thinking about food systems, and within food systems, it's eliminating food waste, it's changing diets towards vegetable source foods, and it's changing production patterns to be much more efficient. And then there are energy systems and the need to move to a post-combustion energy economy. And there's the built environment and the capacity and really enormous promise of building cities to optimize for physical and mental health, but to minimize our ecological footprints. And there's a huge amount that can be done there. In manufacturing, how do we adopt circular economy and just be much less wasteful with materials that we're using? How do we think about economic theory and accounting so that we're not slaves to GDP, but are actually measuring the things that matter to us as a society? And then there's sort of this cultural, spiritual dimension to this, which is that there's something fundamentally broken in our relationship with nature. So how did it ever get to be okay to treat our oceans and our atmosphere as gigantic garbage dumps? How did it become okay to extinguish other life forms sort of with equanimity and not worry about it? And so there's a need to sort of rethink our relationship to nature and to each other as part of this great transition that we're talking about. And so that arc, and to me, the hopefulness of this story, the sense that there's no reason to believe we can't get this right? So that in 100 years, we can't be living in a world where population is just stabilized as part of the demographic transition, and educating girls, and economic opportunities for women, and access to contraception for couples who want it, and where we've already moved to a post-combustion energy economy, and the climate is getting stabilized, and where we're being much more efficient in our production of manufactured goods and food, and where with every passing decade, there's actually more room for the rest of the biosphere. And so that's a place we know how to get to. There's an incredibly rich sort of terrain of solutions, and it's a matter of having the will to get there. And so to me, the partnership part of this is the great transition. If you actually want to achieve fundamental, deep structural changes in how we live on Earth, that requires global scale partnerships across citizenry, sort of an activated global citizenry, the private sector, the policy domain at the very least. And those are the partnerships we're exploring now. So when we talk to, Imagine, that's Paul Pullman and Jeff Seabright's outfit, or we talk to CEOs from some of these really visionary businesses like Beyond Meat or Live Kindly that are sort of planetary health related businesses, or we're part of this planetary emergency partnership that's thinking about the sustainable development goals and interacting with these huge consortia of other businesses. It's all part of this conversation. And what we're really saying is that we need to frame the 2021 super year as a planetary health year, that it's within that that lens, that planetary health lens, that all of these meetings on biodiversity and climate change and oceans and the UN food system meetings, that they all come into focus as actually part of a single cohesive whole where we're moving towards this great transition. And so that, I think that whole sort of arc and that narrative is important.
So Sam talked about the way that humans are crowding out life on the planet. And that's bringing humans and animals in contact with one another in unprecedented ways, creating more opportunities for zoonotic disease, infectious diseases transmitted from animals to humans. Dr. Tedros, Director General of the World Health Organization, has said, we can only prevent future pandemics with an integrated One Health approach to public health, animal health, and the environment we share. Now is the time to take our partnership to a new level. So to discuss what that looks like, I'm thrilled to be joined by Jana Mazet, Executive Director of the University of California, Davis One Health Institute, to expand on opportunities for collaboration to advance One Health. Jana, thanks so much for joining us.
Well, thanks for having me. It's a thrill to be here.
So I'd love to begin with this question. You know, I've been familiar with your work on One Health for years now, but I don't think it's ever been in the spotlight in the way it is now. So how has COVID-19 really highlighted the importance of a One Health approach? And can you tell us more about what that approach looks like?
I'm feeling really charged about the world noticing the One Health approach, because I truly believe it is how we get ourselves out of ever being in this kind of situation again. The One Health approach has two central tenets from my perspective. One is that we look at this connection that you so nicely articulated among people, animals, plants, and the environment. And plants are kind of a new ad because our food systems are critical. And if we don't watch for that as well, we're going to really put ourselves at risk. The other central tenet that sometimes doesn't get discussed enough is that it's a collaborative process that brings in all of the disciplines or the areas of expertise that we need to address a problem. And I think that's where we have, as a society, all the way back to the beginning of time, we've had pandemics, unfortunately, and we have always had this sort of human-centric, arrogant approach that my discipline, what I work on, can fix this problem. I will go work hard, maybe even with my team, to try and find the answer. And what we need is the respect to cross platforms, just like Devex and the Prescription for Progress is trying to do. And we listen to each other, respect each other, and bring our areas of expertise to bear in a collaborative process.
So I want to ask you about PREDICT. And for those who are less familiar, PREDICT was an early warning project under USAID's Emerging Threats Division. And for 10 years, you served as its global director. Can you talk us through the importance of PREDICT, why it came to a close, and what's next?
Yeah, so PREDICT was really innovative approach coming from the U.S. Agency for International Development to really try to identify viruses before they make us sick. And now we know how important that was. Of course, we weren't working everywhere in the world, and we weren't working where SARS coronavirus 2 apparently spilled over and started the pandemic. But what we did do was we brought together teams, multidisciplinary teams in more than 35 countries to really use this One Health approach to identify not only viruses that were making people sick, but also viruses that were in animals that could spill over, and the behaviors that people were doing that would put them at risk. So in PREDICT, we were able to train almost 7,000 people and infect them with the One Health approach. We got 60 laboratories actually working to identify and discover viruses, and we were collecting all that risk data around the world for how people put themselves at risk from these viruses. So I'm really thrilled that those folks were actually the front line in the COVID-19 pandemic and helped their countries identify the very first cases that entered into their countries. And in those countries, their public health systems listened, reacted, jumped right in, and really helped to shut down the terrible effects that we saw in some other countries where we didn't act so quickly.
So I'd love to bring in a couple members of our audience with questions for you. First, let's hear from one of your colleagues who worked closely with you on the PREDICT project in Nepal.
My question to Jana would be, the PREDICT project, a specific project, is over, but moving forward, how do you see the relationship that was built and fostered over the years? How do you see us continuing that? And one big question that PREDICT was able to kind of answer was that there is a larger, bigger need, more so now than any time before, of having a global collaborative project like PREDICT. And US has been, has shown a lot of leadership in the past. There was a lag in between, but things might be changing in the near future. How do you foresee that being continued in coming days, coming months and years?
Well, it's great to hear from my friend Devex, and I'm really thrilled that part of the One Health approach is we build these relationships and we stay together as colleagues, friends, and like-minded researchers in this case to try and solve global health problems. And so we'll be connected forever, but it is a question as how do we do the work? And I think the momentum coming out of this terrible pandemic will mean that we have the ability to work together. There are so many programs now growing in many different sectors. Just in the US, we have many agencies, the CDC, the NIH, USAID, continuing their efforts. But really for an equitable change in global health, we need all of the countries to have their own strong scientists like my friend, and to be working in this environment with a full seat at the table. And that's why I'm thrilled to be participating in the Global Virome Project as we move forward together and have a global coalition of folks that are ready, able, and have all the skills necessary to detect viruses, all the viruses, frankly, before they make us sick, and understand our behaviors that put us at risk.
Thanks, Jana. So you also are co-director of USAID's One Health Workforce Next Generation program, which is an $85 million project to support professionals in Africa and Southeast Asia to address complex and emerging health threats. And I'd love now to go to Pat Kurachitam, who leads the Southeast Asia One Health University Network, with a question.
So my question to Jana would be that, through the investment that USAID imposed on the universities over the last decade, and in terms of the One Health Workforce Next Generation up until 2024, I know that we all are struggling with the sustainable financial investment. So what would be your recommendation to the network, like us, like Southeast Asia One Health University Network, to sustain our effort into the future?
I really think that the future is going to require all sectors coming together. And I think private sectors, again, have not been welcomed in and integrated as much as they should have been with our academic pursuits. And I do think that that's the future. We all know what ignoring the One Health approach and not working together can do to us as societies, as families, as citizens of the earth. And we can pull together, but I do think the private sector, the technology sector, the private pharmaceutical sector absolutely can come together, and then large philanthropy, as well as government funding, not just from the big donor governments, but governments reprioritizing within their own budgets to really put efforts behind this viral detection, discovery, but the collaborative approach.
Thanks, Jana. So we've heard today about Planetary Health, about One Health. We've heard about some of the exciting work that's already taking place. But in terms of what's needed moving forward, any final calls to action? You just talked about other communities that need to get involved, maybe practically how they can do so.
Absolutely. I mean, if the COVID-19 pandemic isn't a call to action, and if we don't change our behavior and think about the earth and the interconnectedness. We're not protected. Even in our own homes, we try to stay home and protect ourselves. We know we can't isolate ourselves and we need to change. I really do believe that we have an incredible opportunity to recognize that the drivers for emerging infectious diseases and pandemic threats are the same drivers that are causing the degradation of our planet, and things that we can also recognize, like climate variability, climate change in the long term, and wildfires that I experience here in my California home. All of these things are connected, and they are all about the health of the planet. We are one species on the planet that absolutely dominates, and we're worried about our health. But if we can combine together the momentum of understanding how we need to walk more softly on the earth and use each other's enthusiasm and positivity to infect those sectors that may be a little more suspicious about whether we can make any changes for good, I think that we will have a much healthier future.
Hello everyone and welcome back. I'm Amrita Byatnal and I'm an associate editor here at Devex. And next today, we're turning to the crucial issue of the burden of non-communicable diseases. To discuss this, we have two esteemed guests with us today. I'd like to introduce Anne Stake, who's the head of strategy, innovation and technology at Medtronic Labs. And we also have with us Zachariah Muriuki, who's a program officer for NCDs at the Ministry of Health in Kenya. We're very happy to have you here today. Welcome.
Thank you. Thank you.
Thank you. Thank you. And yeah, like I said, we could just dive right in, and we can start with you. Especially with COVID, just as we've been talking before, the health systems all around the world have been really stretched. So in this scenario, I'm really curious in terms of how an organization like Medtronic Labs is thinking about, using technology, especially for the care of NCDs, because we've also seen that the resources that were meant for NCDs have probably been diverted towards COVID right now. It's really hard to reach people face to face. So how is technology really being leveraged?
Yeah, thank you so much. I think COVID-19 has really been a case study in how important it is to address the double burden of chronic disease and infectious disease alongside each other. We've seen that with all the resources going to COVID and kind of the response to pandemic, there has been interruption in a lot of the other parts of the health system. But at the same time, I think we're seeing hints at how digital technologies might actually help health systems create more resilience moving forward. And our partnership between Medtronic Labs and Zach and the Ministry of Health in Kenya, which is all about extending care for non-communicable diseases directly to the community, directly to patients using digital health technology, I think is now more important than ever, especially because in the midst of COVID, non-communicable disease patients are at higher risk of mortality due to COVID. So to highlight just quickly how the partnership has been working, we've been working with the Ministry of Health and Novartis and 3 counties in Kenya to train and equip community health workers to go out and screen for diabetes and hypertension using digital technology. And then a underlying risk algorithm allows the community health workers to continue to follow up with patients directly in the community at a specified cadence. On the other side, the health system and doctors can see the data longitudinally to follow up with patients at the right time. And then we also been working to build out a whole suite of educational content and materials with telecounseling, with SMS, with WhatsApp groups, in-person groups to make sure that even in the light of the pandemic, patients are able to continue their care for diabetes and hypertension in particular.
Right, that's really interesting. Zachariah, if I can come to you next, I'd like to know from you in terms of, how has the burden of NCDs sort of being dealt with in Kenya right now, and how does a partnership with Medtronic's lab, sort of help in really trying to use those solutions at scale?
Thank you so much. The burden of NCD in Kenya is increasing every day. As per our STEP survey 2015, which is almost like 5 years old data, that showed that the non-communicable diseases among the population has been increasing. And Kenya is currently facing what we call the double burden of diseases. There's still the infectious diseases, which has now been complicated by COVID-19, meaning that what we used to have like HIV, TB, malaria has now been complicated by COVID-19, which has now hit hard to people with the non-communicable diseases. That notwithstanding, the Ministry of Health and the Kenya government appreciates what we call the public-private partnerships. And that's why we are lucky that Medtronic Labs met us along the way as we were trying to strengthen data for non-communicable diseases. And we have been able to partner in ensuring that this data is captured on a regular basis. Initially, we were not able to have real-time data for people with diabetes and hypertension. But with this partnership, we are able to get real-time data and also generation of monthly reporting, which is factual, which is reflects the true picture on the ground. Initially, the data was dependent on the healthcare worker who was reporting from the ground or from the health facilities. But now with this partnership, the data is able to speak to us on a regular basis. We are able to monitor health outcomes for the patient, which is very, very key. Most of the time, we don't manage patients thinking about the health outcomes. But with this partnership, we are able to tell the health outcomes on a regular basis. And we are excited that this public-private partnership is helping this country to move on in ensuring that we have accurate data and real-time data for management of diabetes and hypertension. Thank you.
Right, that's so important to sort of, keep that partnership going and the relationship going. Here at Prescription for Progress, we've always been really keen on trying to look for solutions and look for models that sort of avoid pilotitis, right? Like this idea of just doing pilot after pilot when it's not really something that can scale. So Anne, if you can talk a little bit about, how this partnership with the Ministry of Health in Kenya is really helping you to achieve that, and how that sort of really ensures sustainability in the long run.
Yeah, absolutely. I'm laughing because we always use that phrase pilotitis as well, because scale is always the end goal. And I think recently we've seen pilots become the end goal, which isn't necessarily, not the best. But with our partnership with the Ministry of Health, I think we built scale into the way we not only designed the technology, but also the way we designed the partnership. So on the technology front, we've been, working with Zach and with his colleagues at the ministry from the very beginning to make sure that, we're aligned with the digital health ecosystem that is developing in the ground, whether that's, interoperability standards or push for integration, making sure that our architecture is up to date and that the technology is actually solving the problems that are most relevant to the health system. And then on the partnerships front, because we are fully integrated in the health system, I think as Zach was mentioning, the importance of public-private partnerships. The end goal is not to end after these 3 counties, but to really expand and have the ministry take over the model and expand it across the country. For us, it's always about not replicating something that's already been done. So we've also been kind of exploring this idea of impact franchising in our models, where if we bring something to the table and we find that we're have a theory of change and someone else brings something else to the table, we don't want to rebuild something that already exists. So always looking for new ways to partner, whether that's with the private sector, with Novartis, for instance, who's part of our private sector or public-private partnership, or with the public sector as well. Always aiming for scale ultimately as the end goal.
Right, that makes total sense in really trying to expand those partnerships as well, and not, just sort of limiting yourself to one, right? Zachariah, is that something that you have gained from your experience as well in trying to diversify your partners and trying to look for new partners, and how has that worked out?
Thank you so much. As Anne has said, we are trying to mobilize more partners. Like right now, I'm in a meeting whereby we are meeting partners who are developing health-related EMRs, electronic medical records. And right now we have people we call health IT. They have developed something we call Kenya EMR. And we have been discussing on how do we integrate the Empower Health into the Kenya EMR. The reason is because we would like as a country to have one that is harmonized and an application that is going to solve our needs as a country. And this is something that the Medtronic Lab is still buying. And I'm happy that we met with some of their staff and they were telling us that they can still integrate this app into a wider software that can address our needs as a country. In the next 4 or 5 years, our dream is to roll out, if possible, into all the 47 counties, not just the 3 counties, because we have seen this particular application providing solutions for us. And as a country, we are looking for solutions and solution providers, and Medtronic Lab is one of them. So we'll be bringing on board many other partners to keep helping us as a country so we can achieve our dream in ensuring that we have one harmonized and standardized EMR that speaks to our healthcare workers and that speaks to provide solutions to our people in this country.
I think you brought up a really interesting point, and a very crucial one at that, of healthcare workers and how they can sort of work with this technology. So, Anne, if you can talk a little bit about how, when the technology is being built, how do you sort of, consider the needs of the healthcare workers on the ground and what they might be facing, the challenges that they might have in front of them while using this technology? Is that something that you put a lot of thought into?
Yeah, absolutely. As I was saying before, we actually designed the technology alongside our Ministry of Health colleagues on the ground. So we actually have teams of local designers in Kenya that are trained in human-centered design, UX design, UI design, ethnography, that work with the Ministry of Health as well as with patients, so that it's really from the beginning trying to solve a lot of the ground level barriers to care that we're seeing, not only from the clinician perspective or the HRIO or the data custodian perspective, but also from the patient perspective. And to give you kind of a quick example of both, I think Zach was alluding to kind of the interoperability conversations right now. So from our perspective, we've been working alongside all of the different staff from the very kind of facility level, level 1 facility, all the way up to the referral facility in the ministry, to understand how the data flows through the existing health systems and how we can plug into that. And then on the patient side, we've been working with local advocacy groups called KDDA, the Kenya Defeat Diabetes Association, to co-develop new educational curriculums that are designed specifically around the patient need and with the patient themselves.
Right, thanks for that, Anne. Zach, if I can just come back to you for one question and then we can wrap up, and I'll come to you for last comments. We talked earlier about how only 1% of health funding is reserved for NCDs. So in a country like Kenya, what does that look like on the ground, and how are you, as part of the ministry, sort of trying to get more funds and trying to sort of use the funds that you have in a better way possible?
Thank you so much. It is very sad that the burden of NCDs globally is increasing, and the partners have been talking about, through WHO, they have been talking about strengthening the finance for non-communicable disease. Unfortunately, it's not translating to results. The same happens in Kenya, whereby about 2 to 3% of the exchequer funding comes to non-communicable diseases. But that, us as program officers, we have been mobilizing funds from other partners. The government has given us that platform and a leeway to mobilize resources from other partners, like the World Diabetes Foundation, the WHO itself, PATH, Medtronic Labs, and other partners who have come on board to help us ensuring that we have the funding for non-communicable diseases. We hope in the next 5 years, Kenya is developing her second national NCD strategy, which is going to be launched this year. And one of the key pillars in the NCD strategy is what we are calling strengthening the NCD financing. And I believe that we have put enough measures to mobilize more resources through the NCD strategy 2021 to 2025. With this NCD strategy, we believe we are going to bring more and more partners on board to fund the fight against this rising burden of non-communicable diseases. We'll also be strengthening the policy advocacy platform. We are going to develop policy beliefs on NCD financing so that we can talk to partners, not only in Kenya, but also globally, so that we can have more and more funding coming along. Like the way infectious diseases have the global fund, we are dreaming to have a global fund for non-communicable diseases.
Mm-hmm.
Yeah.
Right. And I'm sure here at Devex, we'll keep an eye on that NCD strategy coming out of Kenya and keep reporting on, how it's sort of looking to solve this problem. Thank you so much, Anne and Zachariah, for this really insightful conversation. I guess one takeaway that I have going forward is that partnerships are important, but diverse partners are crucial to a project like this, to an issue like this. And the other thing is that, even though the attention is sort of global, the effort needs to be really, really local. And with that, thank you so much. We look forward to speaking to you again.
Well, I want to welcome everyone back to Prescription for Progress. It's been an incredible day-long event here, so many interesting sessions, and this is our last public session of the day. And I can't think of a better way to end the conversation than to bring in Dr. Eric Goosby, someone who I think is widely known to all of you following this, certainly a star in the global health world, former U.S. Global AIDS Coordinator during the Obama administration. He was a special envoy on TB at the UN. You've worn so many hats, Eric, across the years in global health, and currently sit at UCSF, University of California, San Francisco, as a professor of medicine, leading a center there and doing a lot of work around the world. Very engaged. You were on the Biden COVID-19 task force and engaged with the transition. So really great to get a few minutes to tap into your thinking at this crucial moment in global health, right? We've come through, we're still in the middle of this big pandemic globally. It's changed, I think, the way many of us are thinking. So we want to tap into your thinking. This is an event about partnerships. We're trying to look at the future, what's coming, where are we? What are you thinking about? What are kind of your big picture ideas when you see the moment we're in global health today?
Thanks, Raj. It's a real pleasure to be with you today. I think this is the salient feature that is on so many countries and individual minds as we try to have the United States come back into a collegial role in the multilateral discussion, kind of in this post-COVID moment. I think our historical involvement in international work was appreciated, and I think people felt a change in the priorities as the Trump administration played out, appropriated against its priorities. And I think we are eager to pivot back into a multilateral relationship because of the threats that the planet has now are mostly going to be responded to effectively, durably through a shared responsibility pivot.
Yeah, and you're right. I mean, it's a pretty stark from Obama to Trump to Biden. This is a really big swing in the way the world's largest funder of global health sees these issues, sees multilateralism. But, speaking of the global health community, people who are trying to forge partnerships, trying to find a way through this pandemic that we're in now, what is your big takeaway about what's needed today? What do we need to do differently to get past the moment we're in and to create some better future in global health?
Well, I think we need to unpack the impact that the COVID outbreak created really at every level, both from national to provincial to local at a country level, but also the ability for a multilateral response to be orchestrated and concentrated effectively to bring needed resources but needed capability to those settings, countries, regions that did not get a good start. It went across both developed and developing countries in that sense, but I think we're enough past the initial responses by countries and regions in the world to understand that there are deficiencies that could be addressed more effectively or even primarily in a regional approach. To have that regional discussion, we need to have a present multilateral convener and the G7, G20 coordination, participation in that needs to be solicited and supported.
We've talked about this before, and you've been critical of the idea that, you know, our industry, basically our global health community, is very top down still, right? It's very donor driven. It's very Northern, very Western. What do you see as that dynamic, and why is it so important we address that dynamic in the way global health is organized?
Well, I think we will not be successful in bringing the global populations toward a mean of baseline medical services that they have available to them, and just as importantly, that they receive. I think our ability to create both the capability to deliver quality medical care, to sustain that delivery, and to create systems of delivery that allow the populations, the people who need and depend on those services, to hold those allocation decision makers responsible for the decisions they made and the outcomes that they generate. That ability to understand how a program does or does not create an outcome that is desired and that the system is aware of it enough to feed it back into the subsequent planning and budget process for the next year requires a nimble surveillance, analysis, and feedback loop back into appropriator discussion for that to occur. That's something that requires a commitment by, in many instances, the donor resource, the domestic dollar resource, and then foundation and other bilateral kind of streams of input that come in. The country, if it doesn't play that coordinating role at the country level, all of these divergent resources become disarticulated, do not have an opportunity to synergize. The country begins to turn toward the donor and speak to the donor and report to the donor in somewhat of a stovepipe of activity that diminishes the ability to share and have resources coming into the country that creates systems that all can benefit from and not have to reproduce parallel systems for surveillance, for data collection, as well as for procurement distribution systems, et cetera.
So you're talking about basically strengthening health systems, right? Getting the ministries themselves to be in a position of strength, as opposed to the donor, the global multilateral institution kind of coming in and saying, this is what we ought to do, and providing the resources. And it sounds like, if I'm reading kind of between the lines, you're basically saying right now the way global health works too often is the strings are pulled in Washington or in London or in Brussels, and the actual outcomes, the health outcomes, aren't prioritized. Is that sort of how you see things going?
Yes. I mean, I think they've gone that way for years. And I'm just commenting on what I think is just looking at the data in front of us. It's nothing controversial about this in my mind. I think this is how we've set it up, and there are reasons for that. Understanding those reasons has some importance, but it's really not critical to pivot into supporting systems that expand the capability of the countries that are responsible for the populations that the donor is interested in supporting. And I think we don't have too many disagreements in what we're trying to do. It's more aligning with old ways of behaving that had a role to play, looking at large programs that infused significant resources like the President's Emergency Plan for AIDS Relief for one disease. A platform was built that is strong enough to support the response to certainly more diseases, but is a strong enough platform in terms of human resources and lab capability and procurement distribution already stood up and operating to add maternal and child health, family planning, reproductive health services to that same platform without having to create a parallel or build another clinic just for that disease or that function, which is the approach we historically gravitate toward.
Yeah, we're even seeing that with the COVID response, right? Using the PCR lab testing capabilities that were set up for HIV through PEPFAR. What do you think this means for PEPFAR, the way you're thinking? Because I could almost see what you said about needing to be outcomes focused, needing to have the countries in the driver's seat. That seems pretty well aligned in a way to what Debbie Birx, your successor it was in the Obama administration and then in the Trump administration, tried to do with PEPFAR. But there was some controversy around that idea, right, of being very heavy-handed, going to countries and saying, no, this is how you ought to spend the money. This is what the data suggests. How do you balance the desire for those outcomes and results with, with making sure that the countries really do have that position to decide what to do?
Well, I think it's by offering a true partnership, a collegial discussion around, as a donor, this is what we are interested in funding. This is what we have talked and spoken to our appropriators about to fund. These are the outcomes that we believe we're going to create with that. But we want this to be an effort that builds on your vision of what the need is, and that can be a discussion. But we need to agree on the outcomes that we're after. And I want to understand what that donor dollar is doing in the way of the investment for which outcomes, when. And I also want to understand that for the domestic contribution that you are making to this. I want to give and work to give you complete control over management and oversight of those human resources and monetary resources, but predicated on the outcomes that we've both agreed on are achieved. And as that negotiation changes, the relative contribution of domestic versus international, with the goal for a sustainable, resilient delivery system at the end of it, I believe we can work more effectively together with that partnership arrangement than with a top-down dominated, these are what you want to do. I think my 5 years in PEPFAR did build a platform of dialogue and trust with countries around all of these issues. And I think the difference that Debbie took was more proscriptive. And I think it wasn't that the science was wrong or that she was saying something that wasn't true. She was more prescriptive. And I think that we need to look at whether or not that was effective or not and come back with a governance suggestion that I think is driven by outcome.
If you're advising the Biden administration on PEPFAR right now, you're telling them not to go in the direction that Dr. Debbie Birx took PEPFAR, but to go back maybe to the direction that you suggest, which is less prescriptive. Is that right?
Well, I mean, I've talked to them about all of these issues in just the way that we've spoken. I wouldn't have attributed it to an individual. I think there are country examples of Debbie's tenure doing exactly the right thing. I mean, it's not just there's 72 countries involved. There are different relationships. But I do think the trend needs to be partnership, and that we have a shared responsibility in this, that European capitals need to also acknowledge and play a role in. I think the COVID insult, if I could say it that way, has allowed us to look at the reality of what our relationships currently buy. And I think over the next 3 to 6 months, we're going to see a different distribution of the impact of COVID in sub-Saharan Africa, Southeast Asia. And now is the time for us to really galvanize the partnership.
We're getting close to the end of our time here, and I just want to ask you. You ran one of the world's biggest global health institutions in PEPFAR. It's still a fairly young institution, right? It was stood up to address a specific issue of HIV. Over the years, we've seen other big institutions, the Global Fund, Gavi, recently CEPI due to the Ebola outbreak. Now we're in a pandemic unlike anything we've ever seen. Do you want to see the world set up new institutions because of the coronavirus, some new global multilateral partnership, or do you want to see some other existing institutions strengthened? What is your view about where we ought to go from a kind of an architectural standpoint in global health?
Well, I think a pivot to opening the discussion to our colleagues in both the G7 and G20 diplomatic context is critical. That health is a major issue. COVID showed us that. It becomes a political, its solution is through a political vehicle, and we need to marry the dialogue better in getting politicians and the science involved, speaking to one another. But if there is large donor commitment to doing this, I believe if we can crystallize a vision where our partner countries that we are engaged with hold the self-expectation that they will manage and oversee, monitor, and evaluate these programs, that we will work to expand their human and methodologic capabilities to do that and continue that support, not a one point in time, but we are in a relationship that moves forward. So when new threats and new challenges present themselves, we are already in a dialogue and have means of communication that are matured enough to mount and alter a response in real time. We are not there yet. The IHR 2005 is a blueprint of sorts to go back to fill it, but we have to have the will to do it. And that requires a G7 commitment that is not present yet, but I hope the United States can play a leadership role in achieving it.
Well, fascinating thoughts, and I know that our Devex Pro members and our colleagues at Devex are going to be with you in our private session in a moment. Are going to have a lot of threads to pull on there. This is a transformational moment. Something is going to come out of it, and you are one of the people helping to shape that. And so we really appreciate getting your time here today and being a part of Prescription for Progress. Thank you for being here.
Pleasure.
Well, as we thank Dr. Eric Goosby, and I know everybody's giving him a virtual round of applause for those comments, I want to welcome back in Catherine Cheney, my colleague, who has been emceeing and hosting so many of the sessions today. You know her well. Thank you, Catherine, for a fantastic day, for great conversations. It's been just great to be with you virtually. I wish I was with you in San Francisco, but it's been great to at least be with you virtually today.
I agree. Thank you, Raj. Yeah, upsides and downsides to the virtual gathering. Loved being able to bring people together from around the world. But one of my takeaways was in the conversation with Andy Pattison from the World Health Organization, talking about how he convened all these different players from across the tech sector. He talked about traveling to San Francisco just over a year ago. Those in-person relationships, in-person conversations, at least at the outset, are really valuable. And I know, we have so many learnings. We're seeing what technology makes possible. There's so much momentum to build on, and yet everything we're doing now has to be virtual. So we can leverage relationships that have already been built. I think it's a little bit harder to forge new relationships virtually. I hope some of that has happened today.
It is, but I think we need to get those muscles working, because the reality is, to Dr. Eric Goosby's point, our system in global health is still so top down, and so many of the great solutions and where the decisions really should be made are on the ground in health ministries or in communities. If we don't draw those connections, and there's no way all those people can get to the Bay Area, right? So we've got to find a way to make this work. I will say that the idea that Prescription for Progress has, the very basic concept behind it, just every year it hits me even more powerfully how important it is that we connect the huge trends in technology, whether it's AI or data science, back to the global health outcomes we all want to see. Tech is kind of everything now, right? And if it's got to be connected in global health if we want to see us bridge the gaps that exist around the world today.
Absolutely, it's critical, and yet, as you often hear in sessions around technology is only part of the solution. So trust was a huge theme today. Yep. partnership, that shared responsibility pivot that Dr. Gooseby called for, I think is really critical. And I know you may want to mention this, but these conversations are going to be continuing throughout the year. Yeah, tell us a little bit about some of the ecosystem events that are coming up and how people who are following along can tune in. Sure. Well, you heard earlier about our exciting announcement with plans for more coverage of this space, but we also have more events, including one I definitely want to call out happening next week, March 3rd. Devex is partnering with MSD for Mothers and the Bay Area Global Health Alliance, you've all heard about, for a conversation on the role of digital solutions in quality maternal health care. So if you're in the chat, you can see a link to register there, and we hope to see you there next week. And stay tuned, that's going to be a conversation with the WHO, the Gates Foundation, Accenture, and others. We'd love to hear from those of you who are part of the conversation today who might have lessons you want to share, because these events will be continuing beyond next week. Yeah, I just extend my thanks to all of our fantastic sponsors and partners for being a part of this today, to all of you who have joined, the great speakers from all over the world. Devex has grown into a leading source of global health news. And we do that because we know how important these issues are and how much reporting is required, but we couldn't do it without you. So thank you for your feedback, your ideas, your questions, your pushback, sometimes your comments. We need it. And on behalf of all of our editors and reporters reporting from all over the world, thank you for being a part of Prescription for Progress. Thank you.